police were still to make another horrific discovery. His 11-year-old sister, Josephine.
Josephine had been put through a different type of death than the others. He took her downstairs, and she was obviously alive. He had put a rope around her neck over some pipes, and he would raise her up, and as she was dying, and he was masturbating at that time, so she was the target, the primary target, I believe, for this.
The other 3 Otero children had only escaped because they were at school when the killer attacked. The killer had made certain there was no call for help, disabling the phone line before entering the house.
That's what led the investigators to thinking that this couldn't be a random thing. People just don't walk in off the street and murder a family. Couldn't get fined for that. That didn't happen in Wichita.
But Wichita was different now. BTK had arrived. January 1974. The Wichita Police Department was searching for the brutal murderer of the Otero. The victims, a mother, father, and 2 of their children. All 4 had been asphyxiated and strangled.
Why would someone do this to a family? No one would do this just to go in and do it. There had to be a reason for it.
Police thought there could be a sexual motive due to evidence left at the scene.
They were focusing on seminal fluid that was deposited near the body of Josephine Otero. They were primarily interested in determining the blood group, if possible.
Blood typing suggested the killer was blood type O, but that's the commonest type. 40% of people are type O. Before the use of DNA, the test could only narrow down the suspect list so far. For 9 months, police followed up every lead they had. Witnesses provided descriptions, and identities were drawn up. Then, in October 1974, 3 men confessed to murdering the Oteros. But one person knew they were lying.
Those 3 dudes you have in custody are just talking to get publicity for the Otero murders. They know nothing at all. I did it by myself, and with no one's help.
Only the letter's author knew the horrific details.
Josephine, hanging by the neck in the northwest part of the basement. Hands tied with vine cord. Feet clothesline cord. Her glasses in the southwest bedroom.
Only the killer would know. None of this had been released.
FBI profiler Roy Hazel had analyzed BTK behavior.
It is unusual for a serial killer to correspond following a commission of a crime. BTK certainly suffered from malignant narcissism. That's when you begin to consider yourself superior to others, that you're incapable of making mistakes, and you have a desperate need for attention.
He had typed this letter, took it to the city library, and then he called one of the local newspaper reporters.
BTK craved attention and used his letter to taunt the police. Dad tapped him before he struck again. When this monster enters my brain, I will never know. Maybe you can stop him. I can't. He has already chosen his next victim. The code words for me will be bind them, torture them, kill them, BTK. They will be on the next victim.
He's a psychopath, and a psychopath is a very manipulative individual. He's an individual who manages to compartmentalize. In other words, he can separate out what's taking place from his involvement
ままなんですけど、で例えば大阪まで
Greetings, everybody.
してそのベッドを組み立てていただくことができるんですか？
Hello, hello. How you doing?
あ、そうですか。
Can you hear me? Okay.
今見て。うんうん。ああ、ニトリのものなんですけど。
Okay, we
そう
start.
ですか。あ、わかりました。6万と税別ということですね。わかりました。はい。ちょっと
We start.
ええ。あ、そうですね。そうですね。はい。わかりました。はい。はい。はい。わかりました。はい。ありがとうございます。
Okay, we start in 40 minutes. Okay.
酒井ができるって見てるね、引っ越し、あれにかけたやんね。で、かかってきたやんね。
Hello. We start in 40 minutes. Okay.
安くなった、高くなった。
2万安くなった。
安くなった。
It's extremely important for BTK to elicit that response of terror and fear. Then something happened. He didn't get the panic situation for him. He left. The investigators came to me and said there's a possibility this is tied to Otero murders.
Something else puzzled the chief. Shirley Leanne's son saw the murderer at the door of a neighbor's home earlier.
Hello, Abduram. How are you? Hello, Abduran Hamin.
Very few people experience in a lifetime being able to say, I was the target of a serial killer, because most people that are targets of serial killers don't live to talk about it.
Cheryl Sarkozy and Judy Skirl were roommates back in the late 70s, living just a few doors down from Shirley Leanne. But on the day of the murder, the women were out.
I came home and the police said that a man had murdered the woman down the street from me, but previous to him murdering her, he had come to my house and knocked on my door. So the police believed that I was the intended victim.
Cheryl had had a lucky escape, but the roommates think BTK came back the following year.
And I can remember turning on the kitchen light as I'm entering the room, and I looked up and I saw a man in the back window. And he turned and walked away. And by then we had the phone and we had dove underneath the kitchen table for safety and tried to call the police. And we didn't have people until sun came up.
BTK targeted him where he thought he might find women at home alone. He would patrol the area. He would find somebody that looked right to him. And that's how he would target his victims. 25-year-old Nancy Fox lived alone, getting home late from working 2 jobs.
Part of his protection against making mistakes was getting to know his victims, gathering intelligence, where they live, what kind of car they drive, what time they come home.
On the 8th of December, 1977, Nancy Fox returned home from her job at a jewelry store. Hi, Nancy.
Manual and ligature strangulation, hanging. These are very slow and agonizing ways to die.
Sure.
He did take the victims to the brink of death, let them know that they were at the point of death, and then he allowed them to come back. This method of allowing the victim to revive goes to his claim.
Greetings.
Good morning.
Good morning. How are you?
Yeah, good.
Very
Okay,
good.
I'll just
Okay.
go off
We
now.
we we don't we start in a half hour. Okay.
Yeah, I just wanted to check whether it was fine.
Okay. Very good.
Yeah. Right. Thank you.
You're
See you
welcome.
soon.
Okay.
Hello, John.
Hello, I see you, Rosanna.
Hi, John.
How you
Hi.
doing? Okay, you got your seat.
Yeah.
We start in about 25 minutes.
Yeah. So should I go? What I remain online just with maybe the video. Maybe I remove the video. I don't know. So
Okay.
so at least I'm online already.
Let me make sure I got your video address here.
Yeah, please. And
Yeah.
I don't know if we should put the subtitle to the video. What do you think? Because we can do YouTube, but there are subtitles.
No, you can just comment on it.
I can comment, yeah, because
Yeah, that's
nice,
fine.
very nice video. The reason why I ask my colleague because my computer does not work, but also the quality I have to say is much better than those videos that I have. So I think it's and the technique is the same.
Okay.
So
Okay.
mhm.
Let me make sure I got the address here.
You should have, yeah. And then with the but it runs.
Oh, there
as
it is. There it is. Okay.
Yeah, just
got the
remove the
video.
audio. Just remove the audio, please.
Mm-hmm.
Okay, I leave you on because so I can listen what you are doing, and then I remove the video. Okay.
Okay.
During the presentation, John, should I can remove as well the video anytime I wish, but I can be online, you know?
I'm sorry, what'd you say?
I'm saying during the conference, I can as well remove the. I mean,
you can participate. You can talk. You just like
yeah,
a.
but I can. Yeah, I mean, I can also at some point maybe I can just remove the video and stay still in. You know what I mean? Just for a while. You know, just when everybody talk. You know what I mean? We'll give the talk other people. Maybe I can. I can remove the video and that, but still I'm still in. No.
Well, you can do whatever you want. You just let me know. No, John, stop the video, or Dr. Bennett, or do this, or whatever. It's just like at a conference. I mean, you do what you
No, but
want.
it's because I have this option here to stop a video. It means that I stop my video only, no? That my face is not shown.
Well, you're in the corner. You're like a small picture.
Okay, that's fine.
Like I'll show you right now. I'll show you. See, we're not recording now, so I can do this. And I'll show you the video now.
Is the audio okay? This audio, or do you want the headphone?
No audio. Leave it. Okay, hold on. I'm gonna share the video.
Then the video. Yeah, the video without audio, please.
Okay. Okay, no audio. Okay, the audio is off.
Perfect. That's fine. And then I will comment. That's fine.
Yeah. Okay. I'll just leave the video there. Pause. I'll just leave it there on my taskbar.
Perfect. And then you will show. I will see as well. I will comment.
Yeah.
Perfect.
Someday. I've been to Rome, but just at the airport.
Oh no, you never see Rome?
No. I went to Greece. I stopped at Rome for a little bit, but not enough. I was a big student of the Roman Empire in high school. I was a very big student. I took Latin. That was back in the days when you had to take Latin. If you want to be well-rounded.
I studied 5 years Latin.
Well, yeah, you know what I mean. I'm glad I did. It gives you a very good basis for other languages.
Of course, especially. And so, which part of America are you from?
Florida.
Oh wow, beautiful!
Yeah, it is beautiful. I love living here. I didn't think I'd like it here, but I do like it.
No, but I'm impressed that you study Latin. It's very unusual for American people.
What's that?
I mean, it's very unusual that you study Latin. It's very unusual for American people.
Well, I was lucky. I went to a high school. They were very intelligent because when you're a kid, you don't know what's good for you.
Correct. That's true. That's true.
You're in high school. You don't know.
No.
And I was just encouraged. Take Latin. By my counselors, and
Yeah.
I had very good teachers who knew how important Latin was, or how important it could be. And we translated the Gaelic Wars, the Gaelic Wars, and it was great. I loved it. I had a really good.
No, I have to say that still nowadays, can you believe the Roman law is still studied in all the law, in the law school in the world.
Our country's based on that law.
Yeah, exactly. But also,
a lot of countries were based on that law.
Yeah, because it was quite intelligent the way it was. Respectful, and also for elder people, and so I have to say that.
Yeah, I can't believe some of the buildings are still there in other countries, aqueducts and other places.
Yeah, but in UK, this country has been civilized by the Romans, really, because this was really. There was nothing before they came here.
Well, I'm surprised, and so many cities in Sicily and other Turkey and other countries, not just Rome, other places, Africa, Carthage, and
that's true. But you must come to Rome, because Rome is like open museum.
Yeah, so, I know. I love that.
You can see buildings that are there from 2,000 years. They are fantastic. Yeah. Oh my God, it's very.
I loved Athens because I went to a lot of museums. I loved Athens. You know Athens, right? You've been to Athens?
Never been, but I'm sure that is like Rome.
A lot of museums, a lot of great museums.
Even better than Rome, because the culture is older. So to be honest, we learn by the Greek people. So it's, I'm sure that it's much better. But I never had the chance yet.
Okay.
Would like to go.
So you made it to England. How long have you been in England?
5 years.
Oh, okay. You like living there?
Yeah, I like the job, to be honest. I can do what I wish, to be honest, which is important.
Oh, good.
And
you make good sauce?
Sorry?
You make good Italian sauce?
I do, of course. I do everything. Biscuits, bread, everything.
You make your own bread? Oh my God!
It's easy.
You must be the only neurosurgeon in the world that makes her own bread.
No, I like I like to cook. I like the food. I like to combine, the flavors. It's quite relaxing, actually. It's very good.
Really?
Italians for food are quite a little bit crazy. So
I know.
We pay a lot of attention. If you don't really, unless that you are not Italian or real Italian, food is very important. Yeah.
Well, I grew up in an area up north in a place called, in Boston, near Boston. And there are a lot of Italians there, a lot of Italian restaurants. And it makes a difference.
But
the food.
Of course. My uncle was living in Boston all life. I have one of the uncle, and also
he knows the Italian food there. He knows about it.
Yeah. My part of my family, but this 3 generations ago, I have to say, moved to basically the brother of my grandfather moved to America and basically remains American. So we have a part of the family that is American, and we even don't know very well. Can you believe? And then the cousin of my mother went as well to America, and my grandfather came to America, but then he came back to Italy. So unfortunately, all Italian family have some American connection because they immigrated there. So.
It's a beautiful country. I love living here, and I always enjoy coming home. Home to.
No, America is great. What you have, I think nobody have. Nobody has in the world.
Well, we were so lucky that we got a good form of government a long time ago, And you know, it's not perfect, but it's good. It's a good form of government. It's a good form of
No,
government.
no. I mean, America is America, of course. It's
Yeah.
I mean, nothing to compare with our society. I have to say, with our culture, with our. We are still very much. No, I think it's definitely we should be like like America. So everybody should be.
Let's say hi. I'm Aminata. Hi, Aminata.
Hi.
I'm gonna unmute you there, Aminata. Okay, you're still. Oh, there you go. There you go. Okay, go ahead. Hi, Aminata.
I'm training in Zimbabwe under Professor Kalangu.
Oh my God! Great, great. Welcome.
Thank you.
Is Dr.
Hi.
Capullo? This is Rosanna from Italy, but she's in England now.
Pleased to meet you.
Nice to meet you. Hi.
Hi.
Yeah. Zimbabwe. Now, is Dr. Kabullo there? Dr. Kabullo's there, right?
Dr. Kabullo is here, yeah, and Professor Kalangu is who I'm training under, but Dr. Kabullo.
Oh, he's always traveling.
Well, I'm not sure. He may be in town now.
Yeah, okay. Dr. Kazadi, right?
Kazadi Kalangu, yes.
Right.
He's the head of our program.
Right. Yeah, he's, yeah. We've had him on a couple of conferences, but he's hard to get a hold of because he's always traveling.
I have watched some of the conferences he has been on.
Oh, really?
Yes.
Hey, how you doing? A familiar face. Hello, how you doing?
I'm good. How are you?
Good, good. You know how to screen share and all that stuff.
Yeah.
You're a veteran.
Hi, everyone.
Hi.
Yeah, Rosanna's going to present from her smartphone.
Okay, that's great.
Which is very possible, and you can do a quality job.
I'm not so sure it will be okay, but let's hope for the best.
No, we've had quality presentations from Africa,
Yeah,
from Zimbabwe, with a smartphone.
Yeah, I'm so sorry. My computer does not work properly. I don't know what happened. So it's like frozen. So I can't really do all. I cannot connect with the internet connection. And initially yesterday I thought is the internet connection does not work. Instead, I think it's the computer. So there is something. I mean, I need to probably remove the memory. I mean, I need to to free something because does not use the internet. I mean, I cannot use the internet.
You know, we had a conference from China. The Chinese neurosurgeon did a presentation from the parking lot in his car after he got out of work. And he was in his car giving his PowerPoint presentation with his smartphone. And it came out well.
Yeah.
People are after content. They want content. And you can effectively show it. Mm-hmm. In this kind of setting, as you will. You can effectively show a PowerPoint. It doesn't have to be, a laptop or desktop. And I was surprised how people could do it. And Ike Cherian does a lot on his smartphone. Because with computers, there's always problems. So, you guys have been around computers.
My computer is quite old, so I need to buy a new one now because it's not really working properly. But I think because there is a lot of stuff inside, and then at some point
it's a good investment. It's an investment in education. Your computer is different. It's not just for shopping on Amazon. You can use it as a very good tool for education.
So I needed to buy a new one. That's that's it. That's the situation. So now I can't really delay it because if it doesn't work, so it's no point. Without internet, for me, it's like it doesn't work at all. You know what I mean?
Yeah, I know. Well, I don't know what kids do nowadays. Medical students, if they even buy books. Do you guys know? Do they buy books or just get books from online and?
Yeah, I have iCloud with 2 tera, so all the information are online. But the point, so I have everything basically that is in my computer is in the iCloud, so I can reach that in a different locations.
So all the information's in the cloud, all your files and everything.
Yeah, the files is automatically there, so the computer is automatically there. So even if it will stop to work completely today, for example, then I have all the information saved. But it's not that's the point. The point is that it's getting very slow. So, and it means that you need a new one.
Okay.
But yeah, but the Apple, I'm very happy with the Apple. The Mac is really the best, I have to say.
Okay. Okay, Dr. Kabulo, we have another neurosurgeon from Zimbabwe.
Hello, Dr. Bennett. How are you?
Hey,
Yes,
how you doing? I see you have your consultant. You have your consultant with you.
Hello,
very good.
How are you?
Hey, Anila.
Dr.
Hi,
Aminata,
Anila.
how are you?
Hi, how are you?
Good, good. And
Welcome,
you?
everyone.
Hello,
Thank
hi,
you.
good morning.
I think we have a little bit more time. We still have 10 more minutes. Hello, how are you? Hi,
Yeah,
everyone.
hi.
Yeah.
Hi, Dr. Sachandra. Hi, Dr. Rasana. Dr. Kubulu.
Hi. Hi,
And,
nice.
and Anila, I don't know if you met Dr. Kabulo. Dr. Kabulo is from the Congo. He's now in Zimbabwe. This is
Oh,
Anila.
excellent.
Anila is the ringleader here.
It's amazing. It's amazing this program that you can see people and have a conference, in the world. I mean, it's really amazing.
Yeah, it works, I think, for education.
Works perfectly. Yeah, and then I mean, you can share experience even if you are in your sofa. So it's great.
Well, Zoom is getting better and better. It's a platform. They're improving things.
Yes.
The Google Hangout had a pretty good platform, but they really weren't improving it. They weren't, making changes. This platform is integrated with, you can integrate it with YouTube and Facebook, which are powerful for promotional reasons.
Yes.
And you guys don't realize that, but I put it all over Facebook, and Facebook's a great promotional platform. It's really, really good.
Mm-hmm.
So that helps spread the word about what you guys are doing now. Because I spent most of the couple hours on Facebook, sending it to groups. Neurosurgery groups are pretty good because you'll have 1,000, 2,000, 3,000 members. And so you'll reach them. But of course, the neurosurgeon's life, they'll come if they have time, if they have an opening.
Of course. And then, Sunday, maybe people are busy with the family. Yeah, of course. And John, are you able to see how many people are connected to the conference? Are you able to know that?
Approximately. Like Anila said, we had more than 400 the last time. I look at the numbers on the Facebook, on the posts I put, and also it's also live on Neurosurgical TV, which I'll show you right now.
Dr. Rasana, last time we did a minimally invasive spine surgery webinar, and we had put it up on the YouTube, and it was seen by more than 400 participants on the YouTube. So it was a very popular one.
Yeah, it'll.
Wow.
This presentation will still stay on YouTube forever. Okay. I'm showing you where it's. I'm showing where it's on the front page of Neurosurgical TV, and you can see you now, basically.
Yeah, I can see. Yeah.
So that's the more places you put it, the better it is, because obviously, it's like having a TV. The more TVs you have tuned in, the better it is.
Yeah.
So you just try to put it on as many stations as you can, many groups as you can. And people were so Anila, you're gonna kind of handle the order of people and introduce. I'll just stay in the background, and you kind of run the show, okay?
So, John, the plan is that I am actually going to introduce Dr. Abida Shah from India, and she is the one who is actually going to lead the entire session.
Okay.
And then I will just say a few minutes of conclusive remarks, and then we will end. So I will do a bit of introduction, a bit of conclusion, but the entire show will be run by Dr. Abida Shah from India.
Okay, she's not here yet. She's not here yet.
She's here.
Oh, okay. Aminata is going to do it, or which?
I am.
Oh, okay. You're gonna do it. Okay, so I'm just gonna say 10, 9, 8, 7, 6, 5, 4, 3, 2, 1, and then you take over. Okay.
Abhi, I will start and then I will hand it over to you after your introduction.
Okay, Anila. Okay, I'll go 10, 9, 8, 7, 6, 5, 4, 2, 1. And then you
Got
say,
it.
hi, I'm Anila. I'm doing this conference, whatever. And then it's your thing. I stay in the background. I'm a
Yes.
technician because I don't want to confuse people because it's your webinar.
Yes.
I don't want to have people say, "Well, what the heck's Neurosurgical TV?" No, just concentrate on the program. So, and if you need help, just say, Dr. Bennett or John, what's
Sure.
this? If there's a sound problem, I may jump in and say, "Hey, you need to adjust your microphone, or you're not screen sharing." And please, everybody, when you're not speaking, mute your microphone because any extraneous noise will pick up and the screen will go to you. Hello, Ika. How you doing? I'm Dr. Bennett.
Hi, John. How are you? I'm
Welcome.
Yeah.
Welcome.
Hey, everybody.
Dr. Ika, welcome to the ACNS WIN webinar. I'm Dr. Neela Durbar. How are you?
Great time to be with all of you. It's really very beautiful.
We are very honored that you are giving us this lecture.
Thank you so much.
Well, Anila, I don't know, you have your own style, but what I like to do is introduce everybody at the start. But you can do what you want. You can do what you want.
I'm going to let Abhi handle this because she's the one who's going to be, doing all the introductions.
Okay.
I guess we can go in one by one because everyone might not be present in the beginning. So we'll just go with the flow. We'll start with the first speaker and then go on.
Okay. Whatever you want. You control it. You guys control it. So
we still have 3 more minutes. So
yes.
Our first speaker is our first speaker here. I'm just checking.
Dr. Suchanda, right?
Yeah, Dr. Suchanda is here. Dr. Suchanda, you can start first speaker.
Second one, right?
Our first speaker, Sharon, actually, unfortunately, had an emergency clipping to do. So, so she will not be able to join us.
Okay.
So I think you will be our first speaker. So if you want to get start, you have 5 more minutes. If you want to start getting ready your presentation.
Me.
Ready.
It's Suchanda, I think so.
Yeah, okay.
Okay,
John, don't forget. John, the video, don't forget.
Yeah, I got the video ready.
Okay, perfect.
And actually, Neil, you have more time because Neil's not speaking and the other person's not speaking. So
Anil may come. I have received an email, and I think he may join us.
Okay.
Later.
Yeah, because it's right there. It's 5:30 in the morning in Rutgers.
Yeah, exactly. I mean, yeah.
I don't know if they'll make
I
it.
kept him sort of in between so that at least it's 6 a.m. or 6:30 over there by the time he wakes up. Yeah.
It's not going to be tight. You're going to have extra time, I think, for the speakers. Yeah. So if they want to take a minute or two more in their presentations, I think it'll be okay.
And we can also give 5 minutes for any questions. If anyone has any questions, they can even ask the questions to the speaker. Also, there is a chance to chat on this platform. So if any speaker who wants to chat, doesn't want to speak up or want to chat, they can also post their questions on our chat site. It really worked well last time. People had a lot of questions, and the speakers who were already done kept answering those chat questions later on.
Now listen to Anila. She's tough, man. She cracks a whip. Bam.
Okay, then should I go to my connections right now?
We haven't started yet. Whenever you guys are ready. It's still dark in Miami.
Yeah, for you as well, it's night.
Well, I can't show you really because of the background. Okay. There we go. Okay, it's about time. Are you ready?
Anila, you want to start or we want to wait?
Yeah, I think we just.
We can wait a few minutes. If you want to wait a few minutes.
Just wait a couple of more minutes.
Yeah, sure, no problem.
A couple of minutes, I think it's good.
No problem.
Just a few more minutes maybe, and then we can start so that we get the chance for any other participants who wants to join in.
Okay.
You are like practically on the side of the defense.
How do you assemble this group, Anila? Was it arbitrary? You just kind of picked people that...
Actually, I was not the one who assembled the group. It was Dr. Yoko Kato, who was president of the ACNS. She was the one who actually picked us up. And then the best thing was that we all really became very good friends, and we really like working together, and it's very seamless. You know, there is no conflict between any one of us. So it's really lovely working with all the girls that I'm working with.
I wish she'd come.
No, that's right. It's a neurosurgical program.
Pakistan
Yeah, Pakistan The
English is flawless.
No, it's not flawless.
So I think we are 1 more minute, and I think I'm going to start after that.
Abhi, that's the first name, right?
Abhida, yeah.
Okay. Okay. Because we're on live on YouTube right now, but once I press this button, we'll be recording. And once we start, and that'll be the edited. And after we're finished this, I send it to an editor, and he puts a small introduction and maybe takes out some parts that we may have some problems. Well, we will have problems. I shouldn't say if. With computers, you can count on having problems.
I'm just with my mobile, that's all the time.
Well, it's like neurosurgery. You know, you get in there, you don't know what's going to happen sometimes, but you got to be ready for what happens, and you got to try to stay cool.
True.
There's a couple more people here. A couple of people, I don't know if they're speakers. I don't think they are. Farhan, no, probably not. When's the next WFNS ACNS conference? Do you guys?
It's in Kazan next year in May.
Oh, okay.
In May.
Yes.
Kazan.
Are you in charge, Anila?
Say it again.
Are you in charge also in Kazan? Because I still have not received any information about next ACNS.
I am actually not the in charge for the ACNS, Dr. Ika. You may want to contact the secretary over there or Dr. Yoko Kato herself.
Mm-hmm. Yeah, since we elected Kazan, we still have no communication with them, right? I don't know. It's okay.
John, shall we start? What do you say?
Okay, sure. I'll give you a countdown.
Yeah.
Okay, you ready? Okay.
Yeah.
10, 9. After I say 1, I won't say anything. You just take it. Okay.
Yeah.
10, 9, 8, 7, 6, 5, 4, 3, 2, 1.
Good morning, good evening, good afternoon, all the participants of this webinar. I am Dr. Neera Darbar, and I am actually the secretary of the ACNS Women in Neurosurgery, who has actually organized this webinar. I welcome to all our international participants. We are very honored to have them here on our panel. I will introduce Dr. Abida Shah, who will be actually running the entire show. Dr. Abida Shah is also a part of the ACNS Women in Neurosurgery. She conducts and organizes all the workshops and the education. And Dr. Abida Shah is a gold medalist from Mumbai. She is an assistant professor at the Seth GS Hospital and KEM Hospital in Mumbai, India. She's a brilliant neurosurgeon, a skull-based neurosurgeon who has got many awards and has many papers and leadership skills. So Abida, handing over to you to run the webinar. This webinar is on complications of neurovascular surgery. Abida, to you.
Thank you, Anila, for this kind introduction. And this is our third online webinar organized by the ACNS WINS chapter. And we have had previous two webinars on minimally invasive spine and on anatomy of the skull base. And this is our third one. As complications is an integral part of our lives, I think it is important that we have these kind of webinars on complications in neurosurgery. And without much ado, I think we should start. I'd like to invite our first speaker, Dr. Suchanda Bhattacharjee. She is an additional professor at the Nizam's Institute of Medical Sciences, Hyderabad. She's a very active women neurosurgeon in Mumbai, and she's in India, and she's part of a lot of educational activities that happen here. And she's going to be talking to us on complications in giant aneurysm clipping. Over to you, Suchanda. Suchanda, unmute yourself. Suchanda, unmute yourself. Yeah, okay.
Are you hearing me?
Yeah, I can hear you. Go ahead.
Okay. So, good morning, good afternoon, good evening in different time zones. I thank the WINS team for giving me this opportunity to speak here, inspired by Professor Cato. My deepest regards to her. As said, complications in giant aneurysm, complications are a part of life. And we learn more from each complications rather than from your success stories. So I would like to disclosure that this is my mentor and he has a mammoth experience on giant aneurysms, and I borrowed a couple of slides from him so that I can gather all the possible complications which we may have during a course of this difficult surgery. So when you have a bomb like this in the brain, what do? This is a young girl, a 28-year-old girl who came on the...
You have to share your screen. We can't see your presentation. Share your screen.
I'm sharing. Just a moment. Okay. You are hearing me?
I can hear you, but I don't have your screen yet.
Okay.
Okay.
There is a green button on the lower panel of your screen. Yeah, okay. Yeah, okay. Now you can switch on your PowerPoint presentation. I can see your screen now.
Now you can see?
Yes, I can. Yes, I can.
Fine. Is it?
Yeah, yes. Now you can begin.
So this is a case which has come. She's a young lady on the 28th-day postpartum. We didn't have flow diverters then yet, and so we decided for a bypass followed by trapping or clipping, but we have lost her sadly enough while waiting for a day or two. This is yet a very recent case where we had a huge aneurysm of the basilar tip incorporating the outgoing vessels, and came with a classical subarachnoid typical thunderclap headache, and he did not have any deficit. So we went, he also had an ecom aneurysm, if you see here. So what would be the option? Either clipping, where you can tackle both of them, but then it would be a difficult clipping of the basilar top because the neck was involving the outgoing vessel. So we decided for an endovascular, and it was a stent and a coil which was done, and then it would have been difficult to clip because you can see it's way beyond the dorsum celli. So this is yet another scale where flow diverter was used. So these are the type of aneurysms in giant, which the treatment modalities which are used on routine. Now, let me just talk a little bit about giant aneurysm before really going into showing my complication list. Giant intracranial aneurysms has been defined as the ones which are greater than 25 mm. And why are these giant aneurysms a very difficult terrain? Because they have wide atheromatous neck. They're involved in the branches, the thrombus may be there, calcified walls are there, complex anatomy usually has in a giant aneurysm. Then I would like to add the decreasing surgical expertise with the evolution of endovascular techniques. So, it's getting more and more difficult to operate in the coming days because the experience is dwindling to some extent. So if you look at the natural history from this trial, which all of us know, you can see that the posterior circulation aneurysm has an annual risk of bleeding to the tune of 10%, and anterior circulation aneurysm has a bleeding risk of about 8% annually. So we need to do something about them. We just can't leave them unattended, isn't it? So if you look at the natural history as reported by these authors, it was 68% and 85% at 2 and 5 years, and around 100% mortality by another author reported in his series at 2 years, and 75% died if left unattended. So collecting all the major series which were available, you can see that the success story is around 80% and the failure story falls to almost 25%, either mortality or morbidity. But then if you summarize, then this is how it looks. Mortality is almost up to 20% high. But then that was the series of the late 90s and the early 2000s. And in the current decade, if you look, this was the latest paper which came out from, which is published in Neurology India, and it's a single surgeon, Dr. Laligam Shekhar's series, and he had 676 aneurysms which he operated, which included large and giant. And if you look at this, you can see that bypass was required in 63%, of which ruptured was 32% and 68 was unruptured. And fairly, as we know in the literature, the anterior circulation aneurysms were more than the posterior circulation aneurysms. Now, if you look at these results, you can see that still there is a revision graph to the tune of almost 8%. And but anyway, in the long-term follow-up, the results were pretty good. And if you look at his complication rate, you can see that the intraoperative rupture was to the tune of 1% and stroke to the tune of almost 10%. And this is the usual story everywhere. And of course, there are miscellaneous complications like infections or death is almost to the rate of 7.9%. So this is the story everywhere, more or less, here and there 5% plus minus. So what are the indications if you look to operate in a giant aneurysm? I'm not talking of endovascular, someone else is covering. These are essentially the criteria for a bypass in a giant aneurysm as well. Fusiform aneurysm where there is no neck, there are unclippable ones. The aneurysms where it is not possible to reconstruct a traditional neck, aneurysms where flow diverters are risky, and aneurysms where you need to increase temporary clipping time for the sake of reconstruction, or there is a calcified or atheromatous neck. However, the classical indication in surgery remains a giant aneurysm with a wide neck or partially calcified neck with branches arising from the sac. So when do you operate? When the transit time is more than 3 seconds during a simple compression test during angiography. This is easiest and safest, but definitely not the best. Balloon occlusion test is much, much accurate, and the accuracy can further be enhanced with a neurological exam after 20 minutes or inducing hypotension, EEG, Doppler. So just a passing slide about bypass, what you do. You could be of 3 times low flow, where you do STMCA, occipital pica, or in a medial flow, where you use a radial artery, or a high flow, where you use a saphenous vein. Double bypass equals to a radial artery and can give circulation to almost a whole entire anterior hemispheric circulation. So how do we decide in a giant aneurysm? What we do is this: we do a cross circulation if it is poor, bypass with ligation trap or ligation directly. If it is good, do a SPECT. If there is poor reserve, it goes for a bypass. If there is a good reserve, you go for a ligation with a rescue MCA, ISTA bypass in order to increase the, your clippable or manipulation time. So this is how a trapping looks like, and this is how a ligation happens diagrammatically. So once again, to summarize, what we do is ACIC bypass in one stage. In the second stage, carotid ligation or trap ligation. What we do is we do a bypass, and then on the next day, we actually open the neck wound, and we just squeeze the ICA, and then we wait for 20 minutes, and then we see the video. And then we ask the patient to wiggle his leg or the hand. And then if he's fine and able to do the movements, we ligate it immediately. This is how we work here, because all places doesn't have the facility of a balloon angioplasty. So this is a cheaper way of achieving this. So let's come to the specific sites, and I'll talk about the complications in the specific sites, what we encountered. In IC aneurysm, giant or large, the indication remains where the anterocoroidal artery cannot be saved, or where there are lenticulostriate arteries which cannot be saved which are arising from either the MC or ACA in the giant aneurysm. Here we do a high flow ECIC bypass. And now I will show this particular case. You see, this was a case who presented with sudden onset headache, and also partial ptosis was there. You can see giant PCA, PCOM aneurysm, and also an aneurysm arising from the medial side, probably a superior hypophyseal. So, okay. So actually, the plan as we went in was to do in anteroclinoid drilling, and probably we thought we'll be able to tackle the aneurysm, though we kept a control in the neck. But as we opened, and we found that it was impossible to do anteroclinoid drilling, because the other aneurysm, which was the unruptured one, was just glaring at you. So we had to first clip the unruptured one, and then only we could manage to see the PCOM one, which we could subsequently dissect and clip and save the PCOM, and that was a good recovery in a patient. If I could, and so this is one case that went on well, and this was a case where we had to do, this was a large PCOM artery where we had to do a repositioning within 6 hours of surgery. It is an old video, and if you see it here, you can see an atheromatous neck. We used a fenestrated clip and done it. And here we could see we did not have an ICG or anything there, and we could see physically that the anterocoroidal was good enough. So we came, but on reversal from anesthesia, the patient developed right hemiplegia. We just took him in and again clip adjusted. So this tells us a story that if you do not have an ICG to confirm, you may end up going to the theater again, even though it looks good, but then, you need the ICG to confirm when it is available. So this is another complication I would like to say, that this is a right PCOM aneurysm rebled on 24th day of clipping. I'll say this is not a giant one, but I wanted to show this complication, so I included in this presentation. This is the first angio pre-clipping. And then on the 24th day, she came with a GCS7, and this was the CT scan. So when we did an angio, we could see that the clip has actually slipped from the aneurysm. She was reclipped. So this could also happen. Now, this is another complication of a giant IC aneurysm, which actually gave way when we were doing an anteroclinoid drilling. I will just go a little bit, hurry up through the clinoidal drilling part. I could not edit much because, so as we were drilling, you can see it was a huge aneurysm. Unfortunately, I did not put the scans because most of them look alike actually. Huge lobulated ones. You can see that we are doing the drilling here. The drilling continues. And this is the whole aneurysm. We tried to do a retrograde suction decompression, but then it gave away and there was tremendous amount of bleeding. We had no other option but to go on stacking fenestrated clips. And we required almost 6 fenestrated clips to tackle this huge aneurysm. But anyway, we could manage it. So what is the solution, or what is the moral we learned from this story? So the moral is, if you do not have a balloon in the ICA while clipping as a control, then you may end up with such problems. So a good meticulous planning is always required when you deal with such things like that. If you have a balloon here, you could do the suction. This is also another way of doing a suction decompression, but this is the easier way, and this is how we do when that is not available. So coming to that, then if you see the sodium fluorescence of that particular case, you can see there was a good distal flow, so the patient came out well. Now coming to MC aneurysm. When do you do an MC aneurysm? When there is a fusiform aneurysm encircling the M1, flow diverters has a risk of thrombosis of the perforating vessels, M2 branches arising from aneurysm site. Reconstruction time and clipping time can be prolonged if a bypass is there. If you know that STMCA bypass, around 100 ml is given if circulation time is given with a good size SCA. However, the MCA taper requires around 75 ml. And if you do a double bypass, it almost supports the whole hemisphere, as I have told earlier, because it gives around 150 ml per minute. So this is one case of a 23-year-old male who had a sudden onset of right hemiparesis, regained completely by 10 days, was investigated outside with a CT scan and came to us with occasional headache. And these were his scans where you can see a giant aneurysm of the MCA bifurcation. It was an irregular shaped aneurysm. And we went and we did an ECIC bypass in this case and tracked the aneurysm. But the immediate post-op patient had a right hemiparesis of to the tune of 3/5, and he worsened aphasia, and worsening of hemiparesis happened on period day 4, and we had to do a decompressive craniotomy. But the aphasia improved, the neurological improved completely over 3 months, and now he's almost near normal, and he's able to do all his activities well. So this was the post-strapping aneurysm. You can see the aneurysm is gone, but had a stormy post-operative period. Now this is a gentleman, a 65-year-old man. He was circulation-wise, he was not a very good candidate. He had a cardiac stent 1 year back. Ejection fraction was 30. He went to the airport to receive his newborn granddaughter arriving from US, and he fell down and collapsed. And then this was the scan with which he came to us. We had to do an emergency decompressive craniotomy. So this was how the aneurysm was looking, and this was how the angiogram looked. So we told them we'd go for endovascular. We always have a problem with finances for this huge cost, and many times we have to curtail our indications and the treatment we can offer because of this logistic reasons as well. And this was one such case, and they said that no, whatever is the risks, we can go ahead for surgery. So while decompressing, we took up and we did a bypass, and then we clipped both we did trap ligation of both the fusiform part, and then patient did well, but unfortunately bypass was what happened on the post-op. The day 1, he had a massive MI, and we could not keep him with us. He left us. This is one very interesting case. I would like to show that this was a case of, again, I did not put up the pictures of too many things were coming of the same type, MCA large and a giant aneurysm. And the plan was to go in, trap it after doing an STMCA bypass. So when we went in and we found that it was dissectable, and we could find the proximal part MCA, and we could also find the distal part. So what we did is we put clips on both, trapped it, and we trapped it, and we put some ICG, and you can see that even after putting both the clips, the ICG was filling. There was a good flow of the distal vessels and perfusion. So at that point of time, we decided that bypass is probably not required in this case because the filling was good enough. So we went ahead and we just dealt with the aneurysm, dissected it completely, and then of course, we had to reduce the mass effect. So what was done was the aneurysm was torn apart, all the tremors were taken out, and the whole aneurysm was collapsed, and a simple clip was put and them on. So many a times in giant aneurysm, you plan something and you may end up doing something else on the operative table. And that's the importance that you need to gather more and more experience in this type of cases. So now coming to the ECS segment, TACOM segment, giant aneurysms are it's a highly complex region, we all know. DACA aneurysms are either fusiform or giant. Ones are really difficult one, and the treatment modality here could be a side-to-side A3 bypass. I'll just show you a case where there was a problem in the decision making. This was the patient who came to us with the subarachnoid hemorrhage, and this showed a proximal duct aneurysm. It was a giant aneurysm. So we went ahead, we planned for an A3 bypass and then do the surgery. But on opening, what we found as we were going through the interhemispheric fissure, we found that the video is an old one. I'm sorry for the poor quality. And both the ACs were found, and then we saw that there were a lot of collaterals which has already developed and which are arising from the right ACA and going to the left side. And so at that point of time, we felt that it was not required to do a bypass because collaterals were already abundantly there. So we went ahead, dissected the aneurysm, trapped it, opened it, once again thrombectomy and everything, blah, blah, and everything went fine. But the problem in this case, why I like to share, is that there was no big complication as such, but the decision making, we just rushed it and did the surgery with a CT scan. Always we should do an MRI. The size of the aneurysm was 2 times bigger than what was shown on the scan in the angiogram, because that is the filling part. The thrombus part is not shown until you do an MRI, you don't see it. So I missed that part, and that's why I thought that I need to put it up here to emphasize the fact that we always need to do an MRI in a giant aneurysm to see what is the thrombose part and what is the circulating, blood part, because that's how you know the size of the aneurysm while really you are operating on them. So that was the lesson learned from this case. And now, then this was a duct aneurysm where the neck ruptured. So this is the point where if you know microvascular anastomosis, it helps you. The neck ruptured while doing the aneurysm, and this was a border slide from from my mentor, and then that is where you take a 10-0 nylon and you clip it, and you suture the ruptured part, and you can get away at times with it. You can see we are suturing, the neck is being sutured after putting a clip as it was bleeding, and then it sufficed. And then the clips were readjusted more and more in this case till we got the appropriate thing. And the drama never ended here. It went on. And then as I just go through, because these are some of the dissection time, the clip was manipulated. We had to figure out which would be the best position of the clip. We did that. And now you see, as you remove the clip, it again started bleeding. Again, few sutures were given, and finally it could be tackled. So you have to keep all the things handy at time. In whatever you need to do at that point of time. So it's a dynamic thinking process which requires in the surgeries for giant aneurysm, I think. So we could get away nicely with this particular case as well. So let's come to the posterior circulation aneurysm, ideally endovascular. V3 pica, you usually get a fusiform large or a giant. Pica bypass is recommended, or an occipital artery pica bypass. Usually occlusion distal to televelotonsillar segment is very well tolerated. And then I will show this very interesting case of a 33-year-old female who was diabetic, hypothyroid, had sudden onset severe headache, again headache, 2 icters, came to us with GCS5. It was a downgrade fixed palsy was there, and there was a sluggishly reacting pupils with no focal motor deficit. And this was the scan, admitting scan, and so we did a precorneal bar hole and ventriculostomy and a draining, and it kept managed in IC, got better over time, and the angio showed a V4 segment aneurysm with the spasm segments in almost all the major vessels. So she gradually improved, and endovascular team said was not favorable for intervention. So we planned for a surgery, and this was just before surgery. The scan looks pretty good, and then after that we did a left for lateral approach, and the pica was incorporated in that thing.
Two more minutes.
Okay.
Dr. Sitanga, 2 more minutes.
Yeah, so this was the artery, and you can see we put a Doppler in, and then we saw that it was filling, so we had to put an additional clip, and after that we could do an IC, and we saw the pica was patent, so we could get, but she did well, and on the 10th day she had some reserve CSF leak. We put a lumbar drain. She vomited one fine day in the morning, and then we saw that she had a massive infarct, and of course we could not salvage her. So this is another case with swelling in the neck, sitting with difficulty in the swelling, and this was the aneurysm. They did not go for. They had again a finances problem. Sorry, and so we had to do this one bypass and planned for a proximal ligation of the ICA. But on the post-op day, as we were willing her, she deteriorated, and we had a reperfusion. So we should be very careful in choosing our approaches, because too much is also bad, and you see that she landed up with this. And finally, she succumbed with this. So this is our series of this one, 21 operated cerebral. And these are some examples. I'll just skip to them in view of time. So with this, I would like to say that we had a good outcome in 80% of patient, and it's always a learning experience with all the failures which we come and across our way. And this is the outcome with ICA, MCA, DACA, and posterior circulation. And in conclusion, I would like to say that what complications we can expect is an intraoperative rupture, or a post-operative, we can have an ischemia or infarct, or a reperfusion injury, as I have shown in the case examples. And what are the tools to avoid injury are ICG or sodium fluorescent. Guided surgery is better, bypass giving circulation and prolonging clip time, and endovascular are getting better by the day. So actually, that is the thing. So I leave for you all to decide what is to be done in this case. This is a case of a 70-year-old lady, left PCOM clipped 4 years back, right now admitted with us, and on both the sides she has huge aneurysms on both the sides. And endovascular people said that is a very tortuous and probably will not be able to put a flow diverter here. So we planned for a proximal ligation following a bypass. So with this, I thank you all for hearing me, and I hope it was useful to you all. Thank you.
Thank you, Dr. Suchanda, for this beautiful lecture. And it is quite a good series of giant aneurysms that you have. And it's quite nice to see that a lot of bypasses are being done in this era of flow diverter. Do we have any questions for Dr. Suchanda?
We are blessed because, you know, endovascular many people cannot afford, so we have this option in hand.
I'm doing both, so I should not say too much, I think.
Yeah.
So I'm
Okay.
sorry.
Yeah, do we have any questions, or should we move on to the next? Yeah.
I'm very impressed. Can I?
Yes,
comment?
Dr. Rosa.
Yeah. I'm very impressed by the series, because I mean it's a great series, and also the outcome is very good. 80% of the cases that were, and you have adjusted 4 cases that died basically. So it's a very good series. I'm impressed.
Thank you very much. Yeah.
Okay, thank you to Dr. Suchanda. We'll move on. If anyone has any questions, they can put it on the chat later on. So we'll move on to our next presentation. I invite Dr. Rosanna Romani from the UK. She is an associate professor of neurosurgery. She's from Helsinki. She's a consultant neurosurgeon in Finland and Italy. And currently she's doing a fellowship in Southampton. And she's going to present to us complications in posterior circulation aneurysm clipping. So Dr. Rosanna, you can start sharing your screen now.
Thank you. Thank you very much for this nice presentation. And yeah, I had a problem yesterday with my computer. I want just to say to the audience, and I'm doing my presentation. I did this presentation last night with my mobile iPhone. So I hope that it works well. And one of the video is from one of my friends from USA. I go with iCloud. Okay, can you see the presentation?
Yes.
Okay, great. So I must say that this is a very difficult presentation nowadays, because posterior circulation aneurysm, as you know, are best treated with the endovascular route. And especially in UK, the first choice for the treatment of all aneurysm actually is the endovascular route. We have the chance still to do many anterior circulation aneurysm by surgery, open surgery, but definitely the posterior circulation go to the endovascular people. And so we have just a few cases. So when we talk about complication, definitely we need to consider the patient factor, aneurysm factor, and surgeon factor. So when I think about the patient factor, especially in UK, we have a very good selection of the patient, especially for surgery, but for all treatment. I'm, as I said, I train in Helsinki with Professor Nesniemi, and I feel very privileged to have learned the macrosurgical technique with him. In Helsinki, both the center, Kuopio and Helsinki, had an experience of more than 13,000 of macrosurgical operation, especially in Helsinki. Since the 60s, they were treated 10,000 patients by macrosurgery. So when I was there, we were doing majority of the cases, more than 90% by open surgery. And I had the chance to learn as well the posterior circulation microsurgery technique, which nowadays in UK, for example, is very seldom to be seen. But in Helsinki, the selection of the patient was very poor, I have to say. So all patients were treated. In UK, we are very careful. So the age of the patient, but especially the health status of the patient. So if the patient is living in nursing home and has grade 5 subarachnoid hemorrhage, of course, is not treated. But the patient with independent living and with, even if old, has a good chance, we give the chance and this is treated by endovascular people, or eventually, if they cannot, we do the open surgery. So when I talk of posterior circulation aneurysm, we cannot deny that the most experienced neurosurgeons in the world are these three people. And Professor Drake experience by publishing his book in 1996 of 1,767 patients is an experience that I think nowadays nobody will have anymore. Professor Nesniemi learned by Professor Drake, and he reviewed his surgical technique and his pitfall about posterior circulation aneurysm. But what they concluded in their book is that a complicated course of recovery was more common than not. And you can see as how even the most experienced hand, the posterior circulation aneurysm have a lot of complication. When I was in Helsinki, I had the chance to do to do many publications, and especially macrosurgical technique, because we were doing open surgery all the time. And I published this chapter about the microsurgery of rupture aneurysm. This is a few years ago in the Bandock book from the Northwest in Chicago. And you can see in this book, we described all the technique for rupture aneurysm, the anterior and posterior circulation. And if any one of you wish to have this book, of course, I'm happy to email you, and you can find in YouTube all the videos with the description and the different surgical approach. You know, in Helsinki, we are very minimal approach we were doing. It's for anterior and as well for posterior circulation. Skull-based surgeries was really reserved to very complex cases and in seldom aneurysm. Otherwise, we were most likely doing for all cases a very small approach. And you can see this all the technique in this book. We also publish later on, and I contribute as well in the chapter of this intracranial aneurysm, where we review in non-rupture aneurysm our technique. But because nowadays the posterior circulation aneurysm are treated mainly by the endovascular people, I thought that in this presentation probably could be useful to see as well, to review one of the basically macrosurgical technique for those previously coiled aneurysms. So I just analyzed the posterior circulation. We had in this series of 81 patients with 82 aneurysms, 24 posterior circulation aneurysms. And what is really, I think, significant is that by analyzing the factor correlated with outcome, we found that the posterior location, intraoperative rupture, and temporary clipping were associated with a poor outcome. And of these 24 posterior circulation aneurysm, 4 patients died. 1 patient had severe disability, and 1 was in persistent vegetative status. So these patients were treated, the complex cases, treated by the best neurosurgeon, but still with a lot of complication, as Professor Drake already wrote and described in his microsurgical technique. Dr. Bennett, do you want to run out the video, please? Hello?
Yes, I'll do it right now, okay?
Thank you.
Okay.
So
I'm going to stop your screen sharing momentarily, okay?
Thank you very much.
Okay, and
So
I'm going to share the video now, okay?
Yeah, I'm very grateful to Dr. Lanzino from the Neurosurgical Department of Mayo Clinic in Rochester, who gave me this video, which described the macrosurgical technique we use in Helsinki.
Okay, here we go.
Yeah, please.
Okay.
Yes, please. Mm-hmm.
Okay.
Mm-hmm. Thank you. If you can put the whole screen, thank you. So this video, as I said, describes the subtemporal approach for one of giant basilar tip aneurysm. It's a video very didactic, and the quality is extremely good. And as I said, all of my videos are for this publication are online on YouTube, and my computer unfortunately stopped work yesterday, so I couldn't unfortunately upload. But you can see the quality is really good. So this is a 46-year-old lady, and came to the attention of the local doctor because of the cognitive deterioration. You can see this giant aneurysm. The TSA show the flow inside, and then you can see as well from from the carotid injection of the posterior communicating arteries. Very big posterior communicating artery, which it's very important for later on when for the surgical plan. So basically, this patient, which is just an example, with a giant aneurysm, couldn't be treated by surgery in endovascular route, and this mainly because of the perforator of the tip of the basilar region. And also, I have to say that many times when there are large or giant aneurysm, the endovascular route is not really the ideal, because there is a lot of swelling after the coiling with the brainstem compression, and many patients deteriorate because of that. So in this case, Dr. Lanzino made also a occlusion test from the left vertebral artery. This to verify the flow from the perforator, which is extremely important when it's planned. We needed to plan a proximal occlusion of the basilar, which is the best treatment in this kind of giant aneurysm. So the surgical approach for this kind of is the same that we use in Helsinki, and it should be used. So the subtemporal approach, which is a very direct approach, and it's a very, very anatomical approach, as you know. So the patient is in lateral position, and usually the head needs to be parallel to the floor and a little bit tilted to the down. And it's extremely important, the lumbar drain. So I remember that we never did a posterior circulation subtemporal approach without a lumbar drain. And I have to say that in Helsinki, we had also a very good anesthetic team, and always the brain was slack. This is extremely important when you do a small approach, a small craniotomy, because a slack brain is the key. So of course, sometimes when you don't have the slack brain, you need to do a larger approach. But when the anesthetic team is extremely good, and we published many articles about the technique of the anesthesia, then the approach for skull-based lesion or for vascular lesion can be small. And as you know, we publish many articles about the lateral supraorbital approach for anterior circulation or for anterior skull-based lesion. Then what is a key in the subtemporal approach? All of the panelists I can see are very experienced in neurosurgeon, so you know that the tentorial edge, it's the one that needs to be open to gain the enough access to the proximal portion of the basilar artery, and also to expose the anatomy, which is a very eloquent anatomy. And here all the steps that are described in a didactic way. So as you can see, and then basically the visualization of the oculomotor, the trochlear nerve, superior cerebellar artery, and you can see now in the video all the structure. So the tentorial edge, the opening of the interpeduncular cistern with sharp bipolar. We usually, I have to say that we will always alternating the bipolar as a macrosurgical technique and we do as well here in UK. So the sharp bipolar usually has dissection, but many times we use the blunt bipolar to avoid basically the damage of the structure. And you can see here now the superior cerebellar artery, which is exposed. I can't really, the video is very, the brain stem with the star. Yeah, the dissection, of course, of the styloterarachnoid. And then the exposure of the oculomotor. But now the difference is when we open the tentorial edge. For this approach, it's mandatory to open the tentorial edge. So we usually use the clip to hold the tentorial edge. But if you are not familiar with that, of course, the suture is absolutely fine. And actually here, Dr. Lanzina used the suture. You can see here now the exposure of the giant aneurysm, and then the superior cerebellar artery, and then there is just the proximal, I mean, just a small part of the basilar distal portion which is exposed. But when you open the tentorial, then this is evident. Yeah, we usually found the trochlear nerve. Yes, and then the opening of the tentorial edge. So I'm saying that if you're familiar most with the suture, that's fine. You can use the suture for the tentorial edge, but otherwise the clip is much faster, is much practical. Sometimes when you put the clip, there is a small bleeding from the tentorial, but that's not really a big problem, because you can put as well as fibrin glue to stop this suture, this bleeding. When you do the suture, of course, this is usually does not happen, but if it's happened, you can use as well fibrin glue. And this is the difference of the exposure. You can see the basilar, distal part of the basilar, which is in this case extremely important for the proximal clipping, is very well exposed now. And now the dissection of the perforator before the clipping. If you don't have the ICG video angiography, so the angiogenin, then you can use the Doppler, of course, but the ICG is extremely useful. You can see as well the pituitary stalk now on the left of the surgical field exposed. Yes, now the arrow there. and this is the posterior clinoid. So why not to do the subtemporal approach in basilar tip aneurysm? Usually when you have an aneurysm which is quite below the posterior, at the level of the posterior clinoid, but if it's the aneurysm over the posterior clinoid, usually 1 centimeter, then you can do the pterional approach. Yes, the anterior approach, pterional approach. We usually never use, unless that is giant aneurysm, but for small aneurysm, even lateral supraorbital approach, it's enough, or just a small exposure of the temporal side, but you don't need really a large pterion because you can reach the posterior clinoid and the posterior circulation even with this small approach, and of course with the good anesthetic tool. This is the ICG showing the clip, the superior cerebellar artery, and then as well the basilar. So unfortunately, this patient, so the operation went very well. Now it's, you can see, it's very slow, but it's very, very, very good video. The quality is very good, I have to say. So this patient immediately after surgery had a very, I mean, she was unchanged. You can see here the DSA after surgery, which shows still the aneurysm, but the flow was much reduced. As you can see here in the posterior, which there is, this was for the anterior injection, and then now the posterior. But the posterior, the postoperative course, so the patient was basically unchanged with the same symptoms as before surgery. But then later on, this was started daily aspirin by the colleague from Rochester, and then she had as well a postoperative MRI. This after 1 month, where showed already initial thrombosis of the giant aneurysm. This was 1 month later on. So later on, the patient started to have urinary incontinence and also gait worsening. This is 2 months after the neurosurgical procedure.
Dr. Rosanna, just a reminder, you have 2 more minutes.
Yes, finished now, don't worry. And unfortunately, she was found unconscious, and then she basically, there was the plan to review the patient to exclude hydrocephalus, because this probably was the cause of the deterioration, or maybe a sudden rupture of the aneurysm. If you can come back, I don't know, to the slide. I have just the Dr. Joel.
Yes. Yes. You want to go back?
I don't know if I can. Can I go?
Yeah, you want to go back in your presentation there? Oh, wait a minute here.
Yeah. So the presentation, there is just 1 slide.
Okay,
which? Or maybe I can go by myself, maybe.
Yeah, let me get off the screen share. Okay, it's all yours now.
Yeah, it's just, yeah. So basically, I think a giant aneurysm, I agree with the previous presentation, they should be treated with, proximal occlusion or with bypass. I think it's a multidisciplinary surgical planning or treatment plan. And there are no secrets to success. It's the result of preparation, hard work, and learning from failure. And we had many complications about this, especially in posterior circulation. We, in our experience, with the best microsurgical skills, still we have very, very, the outcome is poor, I have to say. So we needed to probably, bypass a simple bypass for future, and still a very challenging lesion with associated with a lot of complication. Thank you very much, and I'm so sorry for the presentation from my mobile. I couldn't. I'm sorry, really, for that, but.
No
it was really, I didn't know plan this.
No problem. Rosanna. It
Thank
was a
you.
good
Thank you very much for the chance. I really feel very, very honored to give this talk to all this experienced neurosurgeon around the world. Thank you.
Thank you, Dr. Rosanna. That was a great presentation. And you must have seen a lot of posterior aneurysm surgery because of your experience in Helsinki, which we don't
Yes.
see too, we don't see too much in this endovascular era. There was a
Correct.
great presentation. Yeah. So
And
it's an art probably that we should also be aware of, and we should train to at least learn to clip some posterior circulation aneurysms, right?
I think this video are nowadays the way we could learn, because I think because we don't have anymore the really every day we cannot see this microsurgical technique. But this video, which for example, this video is exactly the technique we were using in Helsinki. So it's exactly the same approach, what we do, and we can learn about the YouTube video, this kind of way to do surgery, because that's the way today, I think, to learn. We can't really and if we have the skills, so we are vascular neurosurgeons, so we have the skills, we know how to open the arachnoid or to dissect the perforator. We just and we can do that. We can do it. It's not really, and this video are available for everybody. So Ernest Yemi published more than 1,000 video, and all of my video, and if you need some material, article, so chapter, all the techniques is described, so we can do that. And even if they are not every day, unfortunately nowadays, so we can't see anymore. Mm-hmm.
So thank you, Dr. Rosanna. Do we have any questions for her? Okay, I think you can post the questions on the chat and we'll move ahead. We with Dr. Yoshimura. He is with us. He is, can I invite Dr. Shinji Yoshimura? He's professor and chair, Department of Neurosurgery at the Hugo College of Medicine in Japan. And he will be talking to us about complications in endovascular intervention. He does a lot of interventional neuroradiology, and he will be showing his presentation now. Dr. Shinichi? Yes, you can, Dr. Yoshimura, you can unmute yourself. Unmute yourself.
Yeah, I'll unmute him.
Okay, yeah, John, you do that.
Yeah, I'll do that.
Yeah, okay.
We have a lot of people in the panel here. I'm trying to figure out where he is. Sorry. Just give me a second. Oh, there he is. Okay. Okay. Oh, trying to unmute there. Having trouble unmuting him for some reason. Dr. Yoshimura, could you please? There you go. There you go. Okay. You're all set.
Thank you, John.
Okay.
Okay, do you see it?
Yes.
Hi. Hello, everybody. It's a great honor for me to present our experience of the endovascular therapy for large or giant aneurysms. Okay. This is our college named the Hyogo College of Medicine. It is at Nishinomiya. Where is Nishinomiya? It is close to Osaka. It's actually between Osaka and Kobe. Here is our institute. This is my personal experience of the treatment as a neurosurgeon. My total case is over 5,000, and among them, more than 2,000 cases are aneurysm treatment. The number of treatment of cerebral aneurysm is increasing by year like this. And in my department, open surgery is done in around 40% of the patient, and endovascular therapy is in 60% of the patient, according to the patient aneurysm anatomy and systemic condition. Endovascular therapy was performed more than 500 people in 5 years, and the percentage of coiling is 44. Stent assist coiling is 41, and the flow diverter was used in 15%. This is a summary of clinical result of our aneurysm treatment for unruptured one from 2016. And in endovascular therapy group, we experienced a complication in 2.5%. It is not so much, but look at this. This is a summary of complication in endovascular therapy for cerebral aneurysm. Among these 5 patients, all were in large or giant aneurysm. And among them, this is a very light, mild complication, double vision worsening. But the other one, hemorrhage, and this might be due to rupture of the aneurysm. I guess it is 1 month after the procedure. The timing was one day, 1 week, 3 weeks, and 1 month. So complication in large or giant aneurysm done by endovascular therapy were mainly due to hemorrhage. So, pipeline is a major device as a flow diverter for cerebral aneurysm. It is most frequently used in the world. And please look at this animation. Most of you already saw this animation. If aneurysm is located at the paracranial portion, this device is very effective, like this. Just deploy in the parent artery. That's it. It's so easy. It's so simple. It can be done under local anesthesia. Actually, my main series of the pipeline is done under local anesthesia. The aneurysm shrinks like this. So this is a typical case, 55 years old male showing visual disturbance. And this patient was actually a medical doctor, radiologist. He noticed left visual disturbance and he did his own MRI and diagnosed his aneurysm like this. Suprasellar mass lesion was detected. And he came to me and he showed this MRA and the maximum size was more than 15 millimeters. So he already investigated the publication and requested me to perform a flow diverter treatment without coiling, okay? Because of the better visual acuity improvement. So I followed his request, just deployed a single pipeline like this under local anesthesia. And this is just after the treatment. And 6 months later, aneurysm size is smaller than the just after one. And 9 months later, aneurysm was gone on MRA and the visual disturbance was completely improved. This is a follow-up angiography pre and after the treatment. 9 months later, look at this, aneurysm completely disappeared. But we experienced serious complication in this 74 years female. She had a progressive visual field defect like this. Left eye was almost blind and right eye's visual field was getting smaller. And the previous surgeon judged the aneurysm was uncreepable because the IC perforator were running along the aneurysm wall. So we thought what kind of options are available for her, clipping, parent artery occlusion with or without bypass, flow diverter with coiling, or flow diverter only. We had a big discussion with that, and perforator adherence to the aneurysm wall made difficult clipping. Okay, risk of anterior choroidal artery thrombosis due to hypoplastic PCOM. We gave up to perform a high flow bypass plus parent arterial occlusion, and I think this method, flow diverter plus coiling, might be better in terms of to prevent delayed rupture. But patient and patient family strongly requested to perform flow diverter treatment only without coiling. So we followed again this method. This is a movie of flow diverter deployment for her aneurysm. Okay. It was very difficult to navigate the microcatheter to M1 portion. We went around the aneurysm like this, and we inserted another catheter to embolize the aneurysm, okay, in case of something happens. And we connected 3 flow diverters, 3. It's very expensive treatment, but I could manage to deploy 3 stents. Look at this. Contrast media was stable in the aneurysm. So we are so happy with that, but it was suddenly disconnected. So now we navigate the microcatheter through the disconnected 2 stent like this. Now I explain like this. This is just after deployment of 2 flow diverter. Look at this. This deployed very well, seems to be well, but it gradually shrinked and disconnected. Okay, so I navigate the microcatheter between these 2 stents and connected like this. So we were happy with that, and start to select the additional pipeline, but anesthesiologist reported blood pressure elevated gradually. We requested to lower it, but the pressure was still elevating. So I felt strange and did angiography, and look at this. ICA was occluded maybe due to the thrombosis, but contralateral angiography showed the actually elevating the intracranial pressure. It means the aneurysm ruptured during the procedure. So we immediately embolized the aneurysm and the ICA itself. Fortunately, there was a little communication from the contralateral A1 side, but finally we lost this patient. So what was the cause of rupture? It ruptured during selection of flow diverter. We didn't touch the patient at the time. So maybe compression of the aneurysm wall by the catheter, or the aneurysm wall was injured by an edge of disconnected flow diverter during insertion of microcatheter, or flow stress by turbulent flow by disconnection of flow diverter caused rupture. Who knows? But maybe one of them. So we tried to fix our method. Short course of deployment is better. So sometimes we have to go around in the aneurysm to navigate the microcatheter, and we try to deploy like this, but it causes rupture. So we have to go around the aneurysm sometimes, but we have to straighten the catheter by inflation of balloon or something, and deploy stent straightly. This is the ideal method. But sometimes it is not easy. Go around the aneurysm, pull the catheter, and try to deploy stent, but it may sometimes need 2 or 3 flow diverter. It lead to migration of the stent system like this. So we saw that this method, okay, straighten the microcatheter, and after after straightening, we embolize the aneurysm, and by disanchoring, we could deploy pipeline like this. So it is the best one like this, okay, you saw. But if it is very difficult like this, we have to deploy coil and flow diverter. But mass effect may remain. But in this 80 years old female showing hyperpituitarism and visual field defect, we did this plan 2. Okay, patient had such a giant aneurysm, and we delivered coils like this, and this is just after coiling. Afterward, we deployed pipeline like this. So aneurysm was completely obliterated during follow-up. But her visual acuity was not recovered, but we saved her life. So aneurysms difficult to treat by flow diverter are as follows. First one is a tortuous access route. Okay? Navigation of guiding or microcatheter is difficult. Giant aneurysm. Complication rate is reported to be higher compared to large aneurysm or smaller one. Fujiform or aneurysm having branch from the dome, there is a risk of thrombosis in branches and perforators. Maybe this is maybe a basilar trunk aneurysm or MO aneurysm. Ruptured aneurysm in acute phase is not, flow diverter is not reimbursed in our country. Delayed rupture may happen. Okay? And hemorrhage, if patient having hemorrhagic disease like gastrointestinal or women's disease like uterus myoma or something, antiplatelet may cause hemorrhagic problems. So we cannot administer it. So it is not good for the pipeline treatment. So our experience of pipeline is now 100, but in 90 patients, we experienced this serious rupture. And another one is worsening of oculomotor palsy. So basically, the treatment is safe, but we have to carefully select the patient. So recently, endovascular therapy is rapidly increasing, and many patients request it. However, we should select a surgical method when it is safer due to patient anatomical and systemic condition. Okay. This is extra appendix. Annual trend of cerebral aneurysm treatment in Japan. Okay, rupture, clipping for rupture, unruptured are decreasing, and both unruptured or unruptured endovascular therapy are increasing like this. It is almost the same within 2 or 3 years. Okay, 10 or 20 years ago, it was like this. Surgery and endovascular therapy was like this. However, now it is like this. Okay, so it's time to shake hands. Maybe now it is time to be a hybrid neurosurgeon like us and to do endovascular therapy and surgery. So I'm always saying to the young fellow, why don't you start endovascular therapy together with surgery? Is it possible? Nothing is impossible to achieve. Okay, we have actually many overseas trainees and visitors like this. We are so happy. They are from Indonesia, India, Nepal, Vietnam, Colombia, Nepal, Thailand, and also even from Nigeria. We are happy with them. Okay, we are proud to be a ACNS postgraduate training center, and hopefully we can see you, young fellow, in Osaka or maybe in Kobe. Kobe beef is waiting for you. Thank you for your attention.
Thank you, Professor Yoshimura. That was an
Hi.
excellent presentation. Thank you. Thank you very much. And you spoke about hybrid neurosurgeons, and it is becoming a very important armamentarium. I think young neurosurgeons should train in both open and endovascular, because
Thank
then
you.
you have the option of selecting the right treatment for your patient. You know,
Thank you.
use the aneurysm morphology, and then you're able to select the right kind of treatment for all your patients. We in our department also do both. Even I'm trained in both open and endovascular neurosurgery. And to say the least, flow diverters are a good option, but yes, complications can happen. Even
Right.
I've seen one where we had a supracranoid huge IC aneurysm, and the patient did well for 3 days after deployment of flow diverter, but then suddenly on the third day, she succumbed, and we did an autopsy, and we could see that the flow diverter had come out of the vessel. I mean, the whole aneurysm had ruptured. Yeah. So I have seen one complication of a flow diverter, but otherwise they are pretty good tools and they do well. So thank you, Dr. Yoshimura.
Thank
Any
you.
questions for
Thank
Dr.
you,
Yoshimura?
everybody.
Do we have any questions?
Yeah, actually, I have a question, if it's possible, if you have a time.
Yes, go ahead, go ahead, Dr. Rosanna.
No, I'm just impressed by the fact that you did 67 cases under local anesthesia. I mean, this is
Yes.
the first time that I, to be honest, I heard that. I mean, they stand, in session, because usually they are under general anesthesia. So.
Oh, really? Yes.
Yeah,
yes,
we do
I
under
know.
general, to be honest. Yeah, in the department where.
Japanese patient are so
Still.
tough.
So still, because and do you do also the double anticoagulant treatment for
Yes,
you do
of
the
course.
aspirin for life, and then what do you use
Yeah,
usually?
right. A key
Aspirin
point is to test the antiplatelet reaction of the patient before the procedure, because Asian shows a higher percentage of the resistance to the clopidogrel, right? So in that case, we switched to the recently new tenoperazine medicine like prasugrel or some other.
Prasugrel. And then you do prasugrel for 6 weeks or for 6 months. How much do you usually, and how long do you?
Usually 1 to 3 months, we will stop prasugrel and continue aspirin.
For life. Okay, that's fine. Okay. Thank you. Thank you. Very nice. Beautiful presentation. Wonderful. Thank you.
Thank you, everyone. So we'll move on to our next presentation, and I have the pleasure to invite Dr. Eka Vajikramano. He's a very eminent neurosurgeon. He's one of the foremost neurosurgeons of Indonesia, with a very special interest in brainstem, regions of the brainstem, and he's the head of neurosurgical department at Siloam Hospital in Indonesia, and he's going to talk to us about complications in brainstem cavernoma surgery. Dr. Eka?
Vida.
Be a screen share now. Yeah.
Okay, you see my screen?
Yes, I've started. Yes, I see your screen.
You see my screen?
Yes.
Okay, thank you very much. So hello everybody, I'm Eka from Indonesia. I just want to share with you about our experience in brainstem cavernoma surgery. And the title this time is the complication. So as you know that brainstem is only as big as your thumb, and everything is there, nuclear tract, everything is there. So of course, many probabilities of complication if we have, for instance, not a proper approach for that. So let me share with you about a couple of cases we have. So this is definition. Everybody knows that it is like neoplastic because of the head behavior, mostly in a and mostly in the pons. This is our experience in doing cavernous angioma brainstem 60 cases. So what is the typical surgery of the brainstem cavernoma? Besides, we need to know the superficial anatomy, like you see, this is from the atlas of Professor Rotten. you can see that we need to be careful. We need to understand about the surface anatomy, but also in the left side, you see this is like a unseen anatomy that you have to have an imagination. What is happening and what is the position of nuclei on track beneath the surface, because this will influence us how to decide from where the best approach to remove the carcinoma. This is again very important, because again, beside understanding the superficial anatomy, but also the unseen anatomy which is beneath the surface. So the complication, basically every injury on the tract or nuclei in brainstem may cause complication. Of course, such as cranial nerve palsy, tetraparesis, hemiparesis, tetraesthesia, and others. So again, please be careful to see the anatomy and the unseen anatomy of the brainstem before we decide what is the entry to remove the carcinoma. So this is the indication, exophytic evacuable. Of course, this is the indication, and rapid progressive neurological deterioration, significant mass evac, and multiple debilitating hemorrhages. And always discussion, anterior approach or posterior approach. Yeah, several carcinoma are very clear that we have to approach from posterior and some from anterior, from anterolateral, but some is in the gray area. Gray area means that we can approach from both, either one anterior or posterior. And then what is the consideration? So if we approach from the anterior, this is the, we need to avoid the direct tract damage during the surgery, and we need to understand mostly from the anterior is quite narrow window. Posterior, actually, I love posterior approach in the gray area and the clear posterior location of carcinoma, because this is like a wide surgical view. I will show you several cases that we can see from posterior. Again, we can see a very wide operation field. So this is our experience in rupture cavernous angioma. So sometimes the bleeding is inside the carcinoma and cause like a mass evac, like a tumor. So this is very important. If you see there is like if the bleeding leaking through the weak wall of the carcinoma that cause so-called hallucine. You can see this is a very beautiful hallucine that even I saw only once in my life. Because hallucine is very important sign where every neurosurgeon have to know. Because this is the best time to remove when you see the hallucine. Very, very different approach. So this is another similar case. Somebody treated by my neurology colleagues from other city. They thought that is like that was like a hypertensive bleeding, but in fact this is a carcinoma. Just because of too long, they wait more than 3 months, that you see the halo is start to disappear. You see here, this is a halo, but the unclear halo compared with the former case. And this is completely different strategy. I mean, again, the answer is same, surgery, but it's much more difficult to remove. I will show you later. So you see here, this is another case with a mixed intensity of the bleeding of the carcinoma, means this is a multiple bleeding. So in this patient, he got several bleeding. Maybe in the beginning it's not so much clear, then they did not aware. This is like a bleeding of carcinoma. And this is actually like a multiple carcinoma in this young boy. So you can see this is another case with subacute appearance, you can see here. And this is also indication to remove the carcinoma as soon as possible. And some cases, they cause a severe neurological deficit, mostly if the carcinoma located in the medulla. So I will show you also, actually, we have a couple of cases of carcinoma in the medulla, which is the surgery is much more complicated and easy, very easy to get complication. Because the size of the medulla, you know, this is very narrow. It's about 1/3 of the pons. And in the medulla, a lot of nuclear, mostly also lower cranial nerve is there. Then again, so most of the surgery carcinoma in the medulla cause complication. And I share the experience also with my international college. They said also they always get complication in the carcinoma in the medulla. And of course, hopefully the complication is not permanent. I will show you later. And of course, sometimes the bleeding is still small in the brainstem, and we did not do any surgery. This is the halo sign I showed you before. This is the first case of our experience doing brainstem surgery in Indonesia in 2001. You see here young guys with a quadriparesis, and there is a very clear halo sign. Right? And again, at that time, actually, we did not have experience before, but because the patient came in an urgent situation, then we had to do something. He's a poor people, then we need to make like a fundraise for him. And then again, this is the surgery with a prone position. And you can see here, prone position, we just split a bit pons in the lower pants. You see, this is a very beauty of the pons. And again, this is like a moderate, right? This is a gray area, whether you can approach from anterior or posterior, but I love posterior, I show you. And in this case, you see that once I found the capsule, I just removed the capsule, and this is like look horrible because the capsule is surrounded by the liquid of the hematoma, then becoming very easy to remove only one spool, then remove. This is very, very exception case, which we cannot do in every case. Again, because of very clear halo sign in this case, then you can just remove, and in once we can do everything totally in the capsule. And this is the guy still alive up to now. And this is the post-op MRI. And you can see, this is, I told you, if this is unclear, halo is here. So if the case is unclear, you can see this is the same surgery, but technically it's much more difficult because everything is attached to the normal tissue. You can see here, right? So here that we have to piecemeal because we cannot remove once like when the halo very clear. This is another case of mid-print pontine cavernous angioma, and we did approach in anterolateral. You can see here, this is a quite big mid-pons cavernoma. And again, need to understand anatomy from outside. This is a anterolateral approach. We can see we can just pull slightly temporal lobe, and we should cut the 10 because again, you can see here, this is the pons, and this is we have to dissect and sieve the nerve gently. You see here. The best sign, if you see the chocolate landmark of the hemosiderin here, right? If you see hemosiderin from the surface, means this is the best place to enter the brainstem, right? You can see here, we just enter deep and deep, then finally we did total removal in this case. So again, we need to study in the MRI very carefully and select where is the hemosiderin reaching the pile. If we do good there, almost sure that we can avoid the complication unless we don't see hemosiderin from the surface. So this is not the case. You can see here, this is a small actually carcinoma in the border of the pons and medulla. And because this is located in the quite superficial, then we can do surgery. It's not so difficult. This is the carcinoma. You can see here, there's also like a chocolate sign go in the tumor from this landmark. So this is very important to find the landmark. So this is the post-op patient. And you can see here, this is quite similar carcinoma located more down in the medulla, in the border of the medulla and the pons. And this is a deeper also carcinoma. This is quite different. So, I mean, I did complication in this surgery. You can see here, again, we can come down here. And because this is like a deeper position, you can see that we need to split. We need to go to the midline, and finally remove the cavernoma. But you see, this is a sixth nerve palsy. This is the one of the important complications you need to know, because if we need to approach posterior, very easy to get a sixth nerve palsy during the surgery if we did not identify very well. So this is a posterior surface of the medulla. You can medulla and pons, and you can see here this is another case of fractured very young girl. You can see here stria medullare here. Again, I prefer posterior and keep midline. Keep line is very important because actually in the normal position, we do not find any nuclei in the midline. Everything is paramedian, right? And we just need to see where the crossing, the decussatio of the tract in the brainstem. Anyway, in this case, we remove the tumor piecemeal. You can see here. Then this is a post-op MRI. And this is in children much more quicker to get recovery. This is 10 days after surgery, still hemiplegia as when she came. Then 1 month later, you can see the progress is very, very well because it is in children. And again, select the position is very, very important to decide where to approach. This is subacute pontine multiple cavernous angioma. You can see here, this is a multiple bleeding. It's a young boy. And we approach first, of course, from the posterior. And we can see here the surgery. This is the 9-year-old boy with a sudden onset diplopia. You can see, we can meet the tumor first, then the hematoma later on. So this like a layer here means also multiple bleeding. So again, splitting the vermis is very important. Splitting the distal side of vermis is no harm. So in our cases, we don't have a complication of mutism because of the splitting vermis. Because if the location of the cavernoma quite high, if we do not split the vermis, means that we will have to retract severely, and this is not good for the swollen process and maybe more complication during the surgery. So again, this is the boy after surgery, and he came to my clinic regularly and still doing well. So this is not the case of exopitic medulla. You see here, this is the medulla cavernous angioma. Surgery is not very difficult because you know that because this is exopitic, then you can see this is the medulla, cervical cord. And then this another case. This is, I told you before, cavernoma is in the medulla, right? And the patient came with a hemiparesis and the lower cranial nerve palsy. Medulla is one of the smallest part, and again I approach from posterior like this, and again because this is located beneath the surface, we need to split the surface. Again, we need to understand the anatomy, and you can see here we split the surface of the medulla. So slowly here, because again it's located about 1 millimeter beneath the surface. Then you can see finally we find the cavernoma. Be careful, again, keep midline, it's very important. Don't go anywhere else, right? Finally, we found there is the cavernoma, right? Then we can piecemeal remove very slowly. And again, manipulation in the brainstem, mostly in the medulla, has to be very, very, very gentle. Because again, this is only as big as our finger. And again, every manipulation, every touching, every damaging of the nucleus or the tract will cause any complication. So anyway, this is the surgery of the medulla, and this is the patient. And he need to use ND tube 2 months. Fortunately, after 2 months, we can remove the ND tube, recovered. So in several cases, based in our international discussion with our colleague, many of them permanent complication. This is a big problem because again, in the medulla, there are many nuclei of the lower cranial nerve palsy. Once we damage, may cause permanent dysphagia, and this is very, very bad for the patient. This is not the case of the midbrain cavernoma, and this is not so complicated. Also, we can do case of subtemporal approach. This is a lower pons cavernoma we do in a sigmoid approach. You can see here. This is not the case of the midbrain pons cavernoma. This is a 29 years old female. You can see here, this is quite big cavernoma. And it was bleeding 1 month before she came to me. You can see this is a really big one and located in the middle, in the pons and midbrain. You see here, this is quite long, big cavernoma. And again, this is like a wife of poor husband. Anyway, we have made a fundraising for him, and we did the position with a sitting position. This is the best approach. As you see here, with sitting position, we can have a very good view because the cerebellum will gravitatically going lower. And of course, operator is a bit problem, yeah, because this is really very exhausted and very not a good position for the operator. Anyway, but this is the best position to reach the cavernoma. So be careful because we did couple of cases of sitting position and we got a couple of cases of air emboli. This is very important to discuss with anesthesiologists, yeah, to always keep in touch and have to stay there and don't leave the patient because anesthetists will see the change of the ECG when the air emboli coming. It's very important, yeah. If we did a sitting position, anesthesiologists have to be ready in every second, never leave the operating theater while we are doing sitting position in this patient. So you see here, this is the cerebellum coming down gradually, and we can find here, this is again, this is the sign of a chocolate sign here. Then we come inside. Then finally, the target, the goal is total removal of the cavernoma. So again, this is the only brainstem cavernoma we did with a sitting position. And the other is just about posterior and anterior position. So this is the post-op. And I thank you very much for your attention with my sharing of cavernous angioma. Welcome to Indonesia. Anytime we make a fun and make a conference together. Thank you, everybody.
Thank you, Dr. Eka. That was an excellent presentation. Do we have any questions? He's a very
Yes,
senior
I have one.
neurosurgeon.
I have a question.
Yes, go ahead.
Yes, Prof. Eka, thank you for your nice presentation. My question is, how do you differentiate a cavernoma from like a midbrain cavernoma from a midbrain stroke, especially when it's late subacute phase? You do your MRI, it's the first bleed where you don't have a hemosiderin link. It's just the first bleed at the late subacute phase. How do you differentiate? How do you diagnose that this is a cavernoma comparing to a midbrain stroke?
Thank you very much. Normally, I discuss with my colleague in the MR department. Yeah, it will be very clear whether this is a hypertensive bleeding or cavernoma because you can see capsule. And if, for instance, you are not sure, and if the patient condition is still very good, we don't need to be very hurry to do surgery at the time, right? Again, normally we can see capsule very clear in the cavernous angioma rupture, and which is we don't see it in the hypertensive bleeding.
And just a very quick question. I don't know if I missed, but do you use the monitoring during this kind of operation, or do you have experience with that, or what do you recommend?
Thank you, Rosanna. Of course, we do monitoring. So, but when I started in 001, we did not have any monitoring. Again, to me, the most important is again really understand the anatomy and the unseen anatomy, because we should imagine, for instance, right? We go down posterior, we will meet the sixth track, we will meet the sixth track, etc. Of course, we did monitor, but again, be careful. important is understand the unseen anatomy. If possible, of course, try to avoid complication to make any more morbidity after surgery. But this is not very easy. I mean, don't promise to big to your patient, because brainstem surgery is mostly medulla is really complicated. Thank you so much, Rosanna.
No, beautiful, beautiful presentation, and that is great experience. Really impressive. Thank you very much.
Thank you, Dr. Eka, for sharing your experience. And we'll move on to our next presentation. I invite Dr. Roberto Herrera from Argentina. He's the head of neurosurgical services at the Belgrade Adventist Clinic, and he's also Intra MRI program director. And he's an eminent vascular neurosurgeon, and he's going to talk to us on complications in cerebral revascularization. Dr. Herrera.
Hello, good morning, everybody.
Good morning.
I'm sharing my
with meeting. With meeting.
Yes.
Yes. I'm looking for my presentation.
Yes, you can click on your presentation and then it'll come.
Click on my presentation. Okay. Yes. Can you see it?
Yes, yes, yes. Yes, we can see it.
Okay, it's okay?
Yes, yes, it's okay. You can start.
Yes, good morning. In my country, it is 9 in the morning. I'm going to talk, thank you, my friend Anila Darbar and the women in Neurosurgery for inviting me to this web meeting. I'm going to talk about our experience in high flow bypass complication in this brain revascularization surgery. This is my country. I'm in Buenos Aires. This is Argentina, under to Brazil in South America. And this is our clinic, Belgrano Adventist Clinic. It is located in Buenos Aires. Complications in brain revascularization, about specifically in high flow bypass. After 1985, this publication respect the Canadian study, the aspirin was a true executioner of the bypass surgery for almost 30 years and more too. Fortunately, many neurosurgeons continue doing this kind of bypass surgery. And Professor Sant published in 1987 this important work about revascularization surgery in the brain. This bypass was made for me in 1987. I asked for the patient to take she take this angio CT scan, and you can see bypass was patency 28 years after the surgery. I did this bypass, I think 30, 31 years ago. Bypass was patency 28 years after surgery, and this picture was taken 3 or 4 years ago. This is another case, angio CT, 23 years after surgery. This surgery was published in a newspaper in my city, in my country. You can see here, October 6, 1991. And this bypass was patency all this time, with some grade of atherosclerosis, but the bypass was working here. In the last 10 years, bypass surgery, we can see many books and papers about cerebral revascularization. In Google, you can see thousands and thousands of papers about bypass, brain bypass. In the main web page of the university around the world, you can see bypass surgery videos, records in YouTube, courses around all the world, microvascular robotic, anastomosis, and the bypass surgery back to the cover of the main journal of neurosurgery in the world. More than 30 years after Canadian study. In our department, these are the main indication for to do high flow bypass. Cerebrovascular disease in selected cases, surgery to prevent brain ischemia, giant or complex aneurysm is the best indication for high flow bypass. Tumors that involve internal carotid artery and carotid cavernous fistula, when this cannot be solved by endovascular way. How I do high flow bypass? This is a sample surgery, not complicated, because we work in the brain no more than 1 hour. We need 30 minutes to open cilium fissure and 30 minutes to do microsuture in the brain. No more. The rest of the time, we are working in the legs, in the neck, with the craniotomy, but not in the brain. It is different that the direct attack giant aneurysm. But this surgery has different steps, and you have to respect all of them. And this is my team working at the same time to shorten the time of the final time of the total time of the surgery. Yeah, you can see 2 doctors removing the graft, vein, and 2 more doing the craniotomy and the neck exposition. This is the surgical position, the same to any pterygium approach. And the neck incision, the head incision, you can pass the graft in front or behind the ear. This is the craniotomy. This is a big craniotomy. It is not necessary. With a pterygium approach is enough. And here you can see the detail of the tube through which we are going to pass the graft. The neck exposition, common carotid artery, internal carotid artery, external, we are going to do the distal anastomosis here, externally, to avoid brain arrest during the suture. This is, oh, excuse me, this is the way through the graft here. And here we are preparing both legs to get the graft, the vein graft. We use saphenous vein. This is the preparation of the patient. We can use continuous incision or interrupted incision. You can call vascular sorption. You can get the graft with some doctor in our team. It is important to prevent mistake with the orientation of the vein, because if you turn around the vein, the valves of the vein can stop the blood flow and the bypass not work. This is the vein. We pass the vein in front of the ear here. It is preparing to do the anastomosis. This is the external carotid artery, the vein, the punch to the anastomosis. We use this vascular punch. It is normal, it's common punch. they are used for vascular suction, and we prefer continuous suture in the external carotid artery. You have time with internal carotid artery is free. You can, if you prefer, you can do interrupted suture here. We do continuous suture, and this is the distal anastomosis, the vein and the external carotid artery. This is the vein plenty with blood, and this is the vein ready for the distal anastomosis, microanastomosis. Open dura mater, and the anastomosis is made in the normal way, like you learn in the lab. We select middle cerebral artery, temporal branch, and the microanastomosis is a normal microanastomosis. Open cerebral fissure is for the middle cerebral artery. But this is a good detail. Respect this microsuture, distal microsuture. We prefer to do one phase suture with continuous suture, because it shortens the time. We try to spend less than 30 minutes in all the microsuture, distal microsuture, and doing continuous suture on one phase, we shorten the time, the final time. And the other side, interrupted suture. Why? Because it allows the distal mouth of the bypass to be able to grow between one each and one stitch and the other. The wall of the vein and the wall of the artery will be able to grow in the time.
Serrano. Ada Serrano.
Okay. After microsuture, we check with Doppler if the bypass patency is good, if we are sure with blood flow of the bypass. If you have some doubt about the permeability, the patency of the graft, of the bypass, we put a open clamp and occlude the internal carotid artery 50%, and the patient go to the unit, intensive care unit, and the other side with the patient away under neurological examination, you can complete the occlusion of the internal carotid artery, and if the patient is well, you can back the patient to the operating room, reopen the neck, and proceed to occlude definitively the internal carotid artery. Nowadays, you can awake the patient during the surgery. You can occlude internal carotid artery and take 10 minutes, 20 minutes, half hour. And if the patient is well, at the same time, you can occlude internal carotid artery and go the patient out of the operating room. In this case, the clamp was removed and internal carotid artery was occluded definitely the next day after surgery with these two strong threads. It's internal carotid artery here, and this is the external carotid artery, and this is the graft with the bypass wall. Careful closing of the close of the wounds to prevent occlude the bypass when you are procedure to close the craniotomy. And I'm going to show you some cases. For example, you can see here the bypass behind the ear, the vein in young woman. It was a very, very interesting case with this bilateral giant aneurysm carotid cavernous giant aneurysm. We decided to do this first on the right, first bypass here with occlusion of the internal carotid artery with complete solution of the aneurysm. And 6 months later, we did the same on the other side. This is the bypass, no aneurysm, and perfusion of the mediastinal artery. This is the patient, angio CT, angio MRI. This is the same, bypass here, and no more aneurysm. And this is the patient. You can see the bypass grow. This was 9 years after surgery, and bilateral bypass grow. Subcutaneous hematoma are minor complication. You can see this complication, but you can see this kind of complication with subcutaneous hematoma in the course of the graft with this spasm or partial occlusion of the graft, and in this case it is necessary to remove the clot. This is the same. You can see here the vein is thin. In this case, it was necessary to remove the clot to preserve the bypass. Extradural or subdural hematoma are complications. Complication could spoil completely the surgery. It is important to prevent subdural hematoma in these cases. We have this case with refilling of the aneurysm, and we treat it through the bypass because we it doesn't has internal carotid artery, and we did endovascular treatment with coils in the aneurysm and complete occlusion of this refilling of the aneurysm, and the bypass was completely permanent. This is the same. This is another unexpected complication. It is important to have all the surgical field under the vision of the surgeon, because this area was occluded by the surgical field, and we block the skin with the patch pin. When we are going, we pass the graft. We finished the surgery, removed the surgical field, and we found this. We found this. We resolved this complication, opening skin, putting the graft under the skin and closing the wounds, and the patient was well, with no infection, fortunately. This is the same. The age of the patient is not a problem to make a high flow bypass. This case is 74 years old now. Here you can see the bypass, no aneurysm here. This is the patient. This is the bypass working here. Deepest in the cerebral fissure, and this is the bypass after behind the ear and the patient. The high flow bypass can be done too in case of acute bleeding. This patient, 53 years, here you can see the hematoma here because acute subarachnoid hemorrhagia. The bypass, the thrombosis, the aneurysm, and this is the patient.
I'm on a webinar right now.
After surgery, and the patient 6 months after surgery completely recovery. And you can do high flow bypass in children too. This and in previously embolized aneurysm. The high flow bypass can be done in case of previously embolized giant aneurysm in children. You can see this huge aneurysm here, post-traumatic aneurysm. We decided to do high flow bypass. This is the bypass. Proximal suture, distal suture. This is the bypass. This is angio MRI with occlusion of the aneurysm, and this is digital angiography, the coils at complete occlusion of the aneurysm, preserving the distal brain circulation. And this is the patient 6 months after the surgery. Respect the bibliography, you can see that the bypass it has the best results. Endovascular treatment, if you review the bibliography, you can see with endovascular treatment, we have 20% morbidity, 14% mortality. While in direct attack, this is 18 the morbidity and 11 in mortality. But in bypass surgery, you have 11 poor results and only 5% of mortality. These are 84% of occlusion, definitive occlusion of the aneurysm. Again, 40% in endovascular treatment and 71 in direct attack. We have to consider this technique in the treatment of some pathology nowadays. And this is my question: why bypass surgery was always the best treatment or a good treatment for complex and giant aneurysm, and practically was not taken into account for almost 30 years. We have to review this concept. Endovascular treatment nowadays is more expensive, not so good results, but it is more used. And bypass is the cheapest treatment with the best results and less used nowadays. Have the neurosurgeon responsibility in this? Can we change this? I think we have to reconsider the bypass surgery and the high flow bypass surgery in many pathologies. And I think neurosurgeons this concept nowadays, and I think in the next year we go many works, many papers about the application of in-skill-based surgery of the different techniques of the bypass. Thank you very much, and thank you all women in neurosurgery for inviting me. Thank you.
Thank you. Thank you very much, Dr. Herrera, for this wonderful presentation. It was a really great show. And do we have any questions? We can take one quick question as we are running a little late. Okay, I think if you have any questions, you can post it on the chat, and we will go to the next presentation. It is my pleasure to invite Dr. Anil Nanda. Everyone knows him as a doyen of skull base and vascular neurosurgery. He's currently the professor and chairman at the Department of Neurosurgery at Rutgers, New Jersey. And he's involved in a lot of educational activities of the AANS and the CNS. Dr. Anil Nanda, welcome. Dr. Nanda, unmute yourself. Unmute yourself.
Okay, good. Okay. Can you hear me now?
Yes,
Yeah.
I can hear you.
Yes.
Sorry about that. I'm trying to get the video to work. I guess I should just go down. Let me see here. 1 second. Okay, here's the video. Let's see. Okay, is that playing on your thing now or no?
No, you'll have to share your screen. That green thing at the bottom. Yeah.
1 second. I have the video on, but okay. Where does it say share?
Yeah, you have to click the share. Excuse me, I'm John Bennett. You have to click the share button at the bottom of the screen. Click that share button. Okay, and then another screen opens, and you probably will see the video as a choice. Are you clicking the share button?
No, I don't see a share button.
Oh, at the very bottom. Don't worry, we'll edit all this out.
No.
Yeah. Are you using a laptop, desktop?
Yeah, I'm using a laptop.
Okay, at the bottom of your screen, there should be a couple of icons, or Q&A, polls. Do you see those icons at the bottom of your screen?
I've shown hidden icons. I don't see there.
Yeah, we'll show it. Yeah, maybe they're hiding. Just show the hidden icons. Yeah, try that.
Yeah. Sorry about this technical glitch.
That's all right.
Zoom not signed in. I was already in Zoom and I was listening to you guys.
Oh, you're in Zoom because you're here.
Okay.
At the bottom. Or I tell you what, you can send me the URL for the video and I'll play it and share it. Why don't we do that? Can you just text me that? You put in the chat. There's a chat.
This video's playing right now. What should I do?
Yeah, just get me the address of it and text it to me and I'll play it and share it.
Actually, here, let me just try this. Yeah. My computer, Apple III, Apple II. No, that's not what you want. Yeah.
Go on can you see us on the screen? On that screen?
Yeah, I can see you guys on the screen. Yeah.
Yeah. So on the bottom panel, there is a green icon that says share.
Okay, let me try that. Yeah. I'm so embarrassed. I apologize. Yeah, they set me up for this, and I.
Don't worry.
Yeah, 1 second. Let me just turn this off.
It's hard to learn under pressure.
No big deal. I can hear you guys. How should I press on this? Yeah. Okay, let me open it up. Okay, great. So share. Okay, I got share. I did that. Okay, great. Now I'll put, I should press the video again?
No, first click share.
Yeah, I pressed share. I clicked share.
I can't see your screen yet.
Can you see it now?
No.
Okay, wait, let me try again. I just pressed share. Yeah, here.
So, let me show you that.
Share here.
Yeah, okay, I can see your screen now.
There you go.
Okay, great. Let's do it. Amen. Amen, brother.
There you go. Okay.
I can see the video also.
There you go.
Okay, 1 second. 1 second. I'll open.
Yeah.
Okay, great. So can you see this now?
Yes.
Yes.
So this is a cavernous malformation on a young boy. He's 17 years old. This had bled 3 times, and twice he was completely intact. So here you can see I'm going right into the brainstem, small opening right into the floor of the brainstem. And he had bled twice, and the data is the brainstem cavernous will bleed again. The first 2 bleeds, he was totally intact, but in this last bleed, he was hemiparetic and he had slight facial weakness. So because of that, we decided it'd be time to take this. We gave him the option of taking it out, offered him Gamma Knife. You can see we're now in the brainstem right there. Very fine. And you have to, you don't like to retract laterally on the brainstem. Here you can see the cavernous malformation. It has this sort of mulberry appearance like you always expect. And it's a nice plane there. I don't like to retract medially on the brainstem because that's where you get the deficits. And here you can see a beautiful plane. I've had recurrences with brainstem cav mal, so I'm really manic about taking every little piece because sometimes if you leave a little piece, that's a real problem. And once again, I apologize for running late. It was 5:30 in the morning here and I was on, and then Dr. DePart gave to be a little bit later. And I think I overslept, so I apologize for that.
No problem.
So here it is. Now you can see the last residual part. And this is where in the brainstem, you tend to get like, okay, I'm going to get in and get out. But I've seen recurrences, so I just am very manic about getting every little piece off. And here you can see that it's right, a complete resection, last piece that we're removing right there. Here you can see mulberry appearance, yeah. And here I like close seal right there in the center of the brain stem. I actually have slides of him. Just making sure complete hemostasis with these, because I really like using flow seal inside the brain stem, but any hemostatic agent is fine. I think you have to be really cautious that everything is completely clean. We sutured this, and he had definitely worsening after this. He had his facial paresis was worse, but I'd actually like to show the actual films. Let me just get those 1 second here. I'm going to try and pull those out. But anyway, very well. And I just think, I have a series of these brainstem lesions. You have to be very meticulous. I know Eka just presented that he likes to go in the sitting position. I like to do these, I either go from the back or I'll go into hemispheric as well. So I like to have the brainstem fall to the side and they go through the occipital lobe. Let me just see this again. I'm trying to see if I can actually get to the films here. No, I don't have it there. 1 second. But anyway, films look great and he did very well. But I'm open to any questions or anything that you might have. I apologize. I couldn't get this in the right time and it wasn't done properly, but it's the first time I've done this. So, and it's 4:30 in the morning here, so I'm sorry.
That's okay, Dr. Nanda. We have you, and I think anyone has any questions for him, that would be great. We apologize for the early morning drill.
No. And now that I've done this, next time I'll be better equipped. Let's put it that way.
Okay, so we call you again next time, maybe.
Thank you so much,
So
Avida.
we have
I
any
appreciate it.
questions? We have any questions for Dr. Nanda? Okay, so
Thank you so
thank you, Dr.
much.
Yeah. I think we'll move on to the last presentation. And this is actually from a young neurosurgeon who has just finished her fellowship with Professor Kato. And now she's doing a fellowship with Dr. Osaka, with Dr. Ohata, I think, at Osaka City University. And she's going to be talking to us on a recent study on demystifying white matter injuries in aneurysmal SH with DTI. Dr. Sneha Chitra, she's from India. She's trained in south of India, and now she's in Japan. Dr. Sneha, are you there?
Yes, can you hear me?
Yes, I can hear you. Yeah, you can.
All right. A very good afternoon, good evening from Japan to all the eminent faculty there. It's a great pleasure and honor for me to have this opportunity to present this recent work I did at Fujita under Professor Yoko Kato in this panel with so many great people out there worldwide. My respects to all of you there. So this is my presentation here. So demystifying white matter injury in aneurysmal SAH with DTI. I'm thankful to all the faculty at the Fujita Health University and my fellows for making this possible. Cognitive dysfunction is the most common morbidity after aneurysmal SAH. We have so many patients in the follow-up OPDs with one of these problems. It could be memory loss, behavioral changes, an amnestic state, and more often we have the sleep issue. They're telling me, I'm not able to sleep. And these are the manageable ones. We have patients at the other end of the spectrum who are minimally conscious or in the vegetative state. It could be transient. 3 to 6 months is the usual recovery time, or unfortunately permanent in a few patients. So early brain injury after aneurysmal SAH can be both in the gray matter and white matter. Now this is this white matter injury that we are focusing on today, which could be focal or global. It could be due to the blood-brain barrier disruption, neuroinflammation, or ischemic and oxidative stress, or the direct mechanical disruption of the fibers due to the hemorrhage. Now, it is this undetected white matter injury which is not picked up on conventional imaging that is the reason for the cognitive decline in these patients. Now, a very few simple facts about the diffusion imaging. It was initially used in 1990s for stroke. Now we have the tractography or the fiber tracking, which is revolutionary. It is a non-invasive window to the white matter connectivity of the human brain. Now, what are the current applications of tractography? Ischemia, infection, tumors, demyelinating diseases, pre-surgical planning, especially for tumors and epilepsy. A lot of research in diffuse axonal injury is going on, but in the recent 5 years, we have a lot of fiber tracking to assess the cognitive and motor outcome in stroke. And the recovery period, fiber tracking is extremely useful. You can actually see the plasticity and an improvement in the number of fibers in the recovery period. So a small slide to show the basic principles. It is on the Brownian motion of water molecules. We are tracking this anisotropic diffusion of the water molecules across the membranes. And we are placing regions of interest, and we are deriving the microarchitecture of the brain in an indirect way. So these are the eigenvectors X, Y, Z, and we calculate the diffusion ellipsoids and derive the fibers. So this is how a normal fiber tracking in a normal brain looks like. The color coding is red, blue, and green. And when we are going to apply this to study consciousness and cognitive dysfunction, we need to know what is the basis of consciousness. So we have the ARAS, the brainstem, and the thalamus, which forms the core of the human consciousness, the arousal system. And then we have the awareness system, wherein the limbic system, along with the pappus and the mammillothalamic tract, and the basal forebrain bundles, they form the core of what we are, how we emote, the behavior, and the memory. So in short, the awareness. Arousal and awareness make the normal human consciousness. So this is how the pappus circuit and the limbic system looks on a 7 Tesla Hardy MRI tractography taken from a paper by Choi et al. And this is based on the anatomical fiber tracking done by Dr. Abida by the Kingler technique. So because we know the anatomical fiber tracking, it is very difficult to implement the same into the diffusion imaging to derive the fibers. So your basic anatomy is extremely important. This is the ascending reticular activating system tracking done by Rubiano et al. We see these forebrain tracts, which are extremely important and found these impaired in most of our patients. Now, what we did in Fujita was to do this tractography in the post-operative aneurysm patients with cognitive dysfunction. This was a rupture ACOM aneurysm with a GCS of 13, a Hunton Hess of 4. The patient was clipped immediately. This is the post-op CT. The patient continued to remain in E2VT M5, had a very stormy postoperative case, had to undergo a decompression and a shunt. This is the MRI at 6 weeks. This is the shunt-related artifact. And the DTI is showing significant white matter damage. This is the cingulum and the fornix on the right side, shunt-related artifact, and on the left, these are completely absent. So here you can see gross disruption of the fibers in the forebrain and thinning of the cingulum on the side of the aneurysm, the side which was operated left side. Case number 2 was an MCA aneurysm. This patient remained in a vegetative state even 1 year after the clipping, E4 VTM5. This is the CT 1 year after the clipping, which was done elsewhere. And this is the MRI and the fiber tracking. Complete loss of the frontal forebrain bundles. So you can see gross disruption, and no wonder the patient remains in the minimally conscious state. So this is a basilar top aneurysm. Patient walks into the OPD and he collapses right there. And a grade 4 SAH with IVH. This patient underwent a coiling embolization. And post-operatively, his GCS remained to be mild confusion, borderline disorientation. We wanted to know why he was not doing good. So the imaging picked up a very small hematoma, probably EVD insertion related. And the tractography showed a very minor disruption of the fibers. And yet this could be accounted for his memory disturbances and the disorientation he was having. So in summary, we had the cingulum and the fornix in ACOM aneurysm. MCA was the gross disruption in the right frontal forebrain bundle, and the basilar top, even a subtle disruption in the small white matter fibers in the right frontal, led to the confusion in this patient. There was a corresponding decrease of the fractional anisotropy values in all these cases. So Going through the literature, in the past 5 years, we had significant work done on tractography in aneurysmal SAH. They demonstrated changes in the ARES following a shunt operation for hydrocephalus. They could actually show the increase in fibers following a shunt. There was injury of the mammillothalamic tract in patients with SH, especially in the ACOM patients, injuries of the fornix. Again, multiple injuries. It could be injury because of the IVH, SAH, or the ICH. Different parts of the ARAS could be affected, on the whole contributing to the either minimal conscious state or the vegetative state of the patient. Injury of the pappus circuit, again, that is responsible for the memory changes that we very commonly see. To summarize, we have the fornix, cingulum, commissural fibers, and pappus circuit accounting for the memory disturbances, especially in ACOM, the amnestic syndrome, impairment of recent memory alone in mammillothalamic tract, the frontal basal connecting fibers, the behavioral changes. And when this system is knocked off, the ARAS, we're going to have a very bad outcome, decreased arousal, minimally conscious state, and vegetative state. So to conclude, with tractography, early recognition of white matter injury is possible. It is a potential futuristic tool to predict the recovery time. You can actually say the patient's caregivers, see, it's going to take quite a long time, and we can tailor his rehabilitation and pharmacotherapy based on the quantification of white matter damage. We can also say whether his cognitive dysfunction is going to be residual or permanent. What's the future? It's quite exciting. There are research papers on white matter injury targeted therapeutics. And now we have the 7 Tesla MRI. Now, when this is applied for fiber tracking, we can even detect the smallest of white fibers and improve the accuracy of saying, hey, that is where the exact damage is. This is how our post-op patient is going to do. I'm once again extremely thankful for this opportunity to present my research paper. Thank you very much.
Thank you, Sneha. That is great work. And I wish you all the best and that you continue doing work. So we come to an end to our seminar. Dr. Sharon has just finished her clipping, but she won't be able to spend time to do a presentation. So now we have 5 minutes if we have any mutual discussion or any questions for anybody. Anila, unmute yourself.
I have a question for Dr. Sneha. Dr. Sneha, I want to ask you, was your DTI done before the clipping or after the clipping? I believe it's after the clipping. And my question is that how do you know that this is a natural damage from subarachnoid hemorrhage or technical damage done by the surgeon during the technical manipulation? Because in ACOM, sometimes we go through the gyrus rectus and a lot of behavioral and cognitive fibers are around that area. And my second question is, did you repeat the DTI in 3 months or 6 months or a year later to see if there's any change in them?
Thank you. Thank you for these questions. First of all these cases were post-procedural, post-clipping or post-embolization. And yes, very correctly pointed out, the surgical damage is a part of the damage that's caused in addition to the primary damage caused by the hemorrhage. And that one case of basilar aneurysm, the frontal damage was due to the EVD. So it was nowhere directed to the SAH or the IVH. And regarding the second question, yes, we propose to follow up these patients at 3 and 6 months. This was done last month. All these patients were collected over the last 30 days. So we have a proposal to follow up at 3 months and 6 months. And there are research papers which have shown the recovery in form of increase in number of tracts and improvement in the FA values when they were followed up at 3 and 6 months. That is exactly the prognostication value of this fiber tracking. So yes, we propose to do that. Thank you.
And then the fibers you're talking about is the fibers mostly that are going anterior posteriorly, right? The green fibers, not the commissural fibers that are going right to left.
Yes, the frontal forebrain bundles are the green ones, but the cingulum and the pappus fibers also have a part of the association bundles. So it is not all or none. It is a combination of several fibers. And the 3 Tesla MRI is still not enough to pick up even the smaller bundles or the smaller association fibers. So we would need more cases and more reporting.
Okay, great.
Anila, what happens is in SAH, probably the anterior commissure is there, which is a big component of the limbic system with a lot of emotional memory. Then you have the fornix that is right behind it. And then from the mammillary body, you have the tract going up to the cingulum and down to the brainstem in the mammillotegmental tract, and then the medial forebrain bundle. They're all the key structures probably involved in consciousness, memory, and that kind, which might be damaged. Which might have incurred damage due to the SAH itself. I mean, that's what I feel.
Yeah.
Because all of them are close by.
Yeah. So.
That's true. That's true.
Great. So, John, yeah, sorry, Abhi, go ahead.
No, over to you, Anila. You can.
Okay, great. So, John, I think it's time for us to conclude. I want to thank all our international participants. I want to thank all the attendees, and I hope you had a lot of learning from the giants that we had today. Dr. Ika, Dr. Anil Nanda, Dr. Roberto Herrera, Dr. Yoshimura, Dr. Rosanna, and Dr. Suchandra and Dr. Sneha. I thank to all of you for accepting to come to this webinar, educating the future neurosurgeons, educating the current neurosurgeons as well. And I hope you enjoyed it. I just want to let you know that this entire presentation is available on YouTube. So in any case, if you have a residency program and you want to show it to your residents, you can just show it directly from the YouTube. I am certainly planning to show it to my residents this Tuesday. So thank you, everyone. And John, back to you now.
Oh, hi, Anila. I'm John Bennett of Neurosurgical TV. It's a pleasure working with the neurosurgical community, and we hope to continue these excellent presentations. Thank you.
So thank you, everyone. I think we can disperse.
Okay, thank you.
Thank you. Thank you, everybody.
Have a nice day, all of you. Bye-bye.
Yeah.
Thank
you, Suchandana. Bye. Thank you, Sneha. Thank you, Dr. Rosanna. Thank you.
Thank
for
you. Thank
coming.
you to everybody. Thank you.
Bye. Yeah, bye.
I'd like the people that haven't been introduced to say hello. Hello, Baran in Turkey. How are you doing? Can you please introduce yourself?
Hi everyone. Thank you for all conversations and the lectures. So,
thank you. Nice to come. Hey, Khalif, how you doing?
Hi, how are you, John? I'm doing great. Greetings from Nairobi.
Oh, wow. That's good.
Yeah, big conference in Nairobi. When is that conference, Khalif?
It's going to be next year, August. We're having the
August.
Continental Association of Neurosurgeons.
Okay.
We'll
Very
be hosting
good.
the Continental Association. Yes, and we invite you all. Mark your calendar.
Okay, Khalif. Manas, can you please say hello? I haven't seen you for a while. Can you, Manas, you still there?
And hello.
Yeah, hi. I haven't seen you around for a while. The last time was like 2 years ago, right?
Yeah.
Yeah, the Indian Pediatric Neurosurgery Conference.
Yeah.
Is your camera working? Can we see your face? Maybe not. Maybe not. Well, just introduce yourself briefly, Manas.
I work at Hyderabad. It's the central part of India, and I do a lot of endoscopy and skull base and cerebrovascular.
Very good. Welcome, Manas. Dr. Kabulo, can you please introduce yourself?
Thank you so much. My name is Kabulo from Democratic Republic of Congo. I'm currently final year neurosurgery resident at the University of Zimbabwe.
And your screen sharing is working pretty good. Yes. You see that background? You can put backgrounds on your screen. By the way, this is not being recorded. But yeah, you can all put backgrounds on your screen of a hospital or whatever. You just go to the video, you go to the camera button, open up the menu, and it'll say virtual backgrounds, and you can upload a picture. So let me show you the backgrounds that I have. I have some pretty good ones. That one is a popular one. And there's a couple more. Let's see here. Rain. So you can kind of experiment with it. Okay. Let's see, who else is it? Anyone else have something? Let's see, anybody else that hasn't been introduced?
No, I did not understand how you change the background.
Okay, at the bottom of your screen, do you see that little camera? It says stop video.
Yeah.
Okay, the next to the right of that, it's a little arrow. It opens up a menu. And in the menu, you should see choose a virtual background.
Okay.
Click that. Another screen opens, and there's an add image option. You can add an image from your computer, whatever image you want.
Okay.
So why don't you give that a shot? Dr. Kabulo has one. I have one. Dr. Shah, you can try it.
Yeah. I'm trying to. I can't get it.
You can't get it, and you don't see the option, Anila?
No, I don't see the option.
That's because you probably don't have the latest version of Zoom. You might have to. Yeah, just go ahead, do it now. It takes just a second. Download the latest version of Zoom, and you should have that option on the menu.
Okay.
But it's good. You could put the background of your working place, a hospital, an OR, whatever. It's an option. Is anyone else trying it?
Yeah, I tried.
There you got it. Oh, look at that.
Yeah.
She's a smartphone wonderkin.
No, actually, this is Italy. This is Italy. One of the pictures that I took a few weeks ago when I was in Italy. It's cloud. Wow. I'm sorry. Yeah, I'm usually cloudy.
That was good. That was quick.
John,
that's great.
Have you tried it?
One of my medical student, Kainat Siddiqui, is in there. I would like her to introduce. She is quite keen to become a neurosurgeon. She's been attending all our webinars here. Kainat, are you there?
Yeah. What's her name?
Kainat, Kaynat. I don't think
Yeah, ma'am.
Please introduce yourself to us.
Yes, I'm here.
Go ahead.
Hi, everyone.
Put your camera on. Your camera's
Put your camera on.
The value of this platform is
I'm here.
Okay.
We want you just to show your face and introduce yourself, Kainat. That's it. There you go.
Yeah, I'm here.
There you go. There you go. Hello.
Hi. Hi.
Where are you from? What do you do?
I'm from Pakistan, and I'm currently a fourth-year medical student from Janassan Medical University.
Okay, welcome.
Welcome.
It was amazing.
Well, you can come to any webcast. Once you see an announcement, the link is given, and you're welcome to come to any neurosurgical webcast, as are all your neurosurgery-loving friends.
Okay. Thank you so much.
You're welcome.
Okay, I will be leaving now. So thank you all, and hope to see all of you very soon. Bye, everyone. Bye-bye.
Thank you. Bye-bye.
Very much. You put together a great webinar.
Yeah.
Thank you.
Bye, everyone. See you.
Bye.
Bye-bye.
Let's see. Santosh, are you there? Santosh, Rosa Pena, that haven't been introduced yet. Sylvia Sandhu. Is anybody there? I'll mute you all here so you can say hello to the audience. Actually,
hello.
Yeah. Hey, hi, Sylvia.
Yes. Hello. My name is Sylvia Sandhu. I am a resident from Romania, Bucharest, and now I am in France for a fellowship at Marseille. Thank you for a very nice seminar. It was very teaching.
Romania, right?
Yes, Bucharest.
Okay, yeah, Elena Nestio, she head of the Walter Dandy there in Romania. I don't know if you, we've had a few webcasts with her. She did a webinar on how to become a dandy organization, actually. Anyways, but welcome, and you're welcome to come any of the webcasts.
Thank you very much. Thank you very much. Bye.
You're welcome. Rossi, Pena, and who else? Santosh, if you want to introduce yourself. It's a good chance to meet people from other parts of the world. Let's see, Santosh, you there? No. Rossi? I guess not. Okay, everyone.
All right.
I'm going to go now. Hey, it's good to see you again,
John.
Doc.
Thank you.
You did a
I'm going to
presentation
leave now.
before. Okay.
Thank you.
Thank you
See
all
you
for
all.
coming.
Yeah.
It's going to be all
Bye-bye.
It's recorded, and I'll send you the videos.
Thank you very much.
Okay, you're welcome.
Claro, o sea, él va a ver que se introdujeran también. Dice Rafael Nera.
Okay, Dr. Cabullo, see you later.
Thank you so much, Dr. Bennett.
Okay, we'll see you later. Thanks for coming.
It's okay.